Good morning.
Morning.
Good morning.
Good morning.
Good morning, Anne-Sophie.
Good morning,
Laurie,
winner.
Good morning. C'est toi qui commence, je pense. Est-ce que tu veux commencer à partager ton écran pour
Ouais,
on a
ça
du
marche.
temps, là, il y a pas de...
Anne-Sophie, I don't know if I don't remember if you were involved in the emails with Jake, but can
Yes,
you make
I saw
sure?
him.
Can you make sure to bring up at the RPC this afternoon regarding the senior teaching that you guys do in week 2 and week 3? If one of them can be pushed back by maybe half an hour, that way we can confirm we can do our POCUS rounds every week, every month, either on week 2 or week 3.
Yeah, I've seen the emails actually, and it's on the RPC agenda.
Okay, because even though Dr. Stern doesn't do resuscitation all the time in week 1, I still don't want to remove him from that opportunity. And then
Yeah,
of
no,
course
I agree.
RPC is week 4. So if you can tell us which of the weeks 2 or 3, we can pencil in regular POCUS rounds, then that would be great. As soon as I find out, as soon as you guys let me know today, I'm going to create a schedule to put together.
Yeah, I'll send you a follow-up email as soon as I'm out of the RPC meeting. Actually, is that okay?
Perfect.
Yeah, I agree. Week 2, I've seen the email. Jake was replying, so I didn't bulge in. But yes, I think week 2 and 3 in the context is probably the best bet, and it'll fix a lot of issues because there are quite a bit of journal clubs happening, and a lot of residents want to attend. Even same for the M&M rounds at the Jewish, and it's just impossible for us to go to all.
Mm-hmm.
You have to stop being a resident and just be there for meetings and rounds.
Well, that's the thing.
You have to choose, you can't do it all.
My studying could tell you that.
Laurie, is Max less grumpy?
Oh my God. Yes, this morning he told me. This morning he was actually in a very good mood. But, oh God,
why is Max grumpy?
Because he doesn't know how to multitask. Man, sometimes they can have a bit of it.
Be careful what you say.
No,
be careful with the end of that sentence.
One of his employees had a back pain and couldn't work. So all of a sudden he had to work again because Maxime is the boss now, So now he had to work physically. He told me it's been such a long time since he sanded the floor. It's okay.
If you could let us know with the email I sent or the text I sent him, that would be great.
Yeah, he's doing that today.
Okay.
Anybody else needs to do their floor?
Me in like a year because I bought a new place.
Well, congratulations, and I will tell Maxine. Do you see my screen, by the way?
Yeah, we do actually.
Oh, perfect.
It's good. We're already 14 and it's only 8:57.
Oh, because they know that I don't like people when they're late.
Laurie.
Lala.
Want to do a replacement shifts.
What?
Hey, yeah, that's it. Replacement shifts. That was the plan like a few years ago.
Oh, that's true. We stopped doing that, but that might be good. There are a few people logging in like 15 minutes after.
I don't have time to play police anymore.
I can play police.
So I emailed Leila for to book the Sim Center.
Ouais, j'ai vu. I think it's we'll have to discuss. I mean, it's either July or later or at the Jewish. So
the thing is, if we do it at the Jewish, we need models. That's the thing, and then we don't have really a budget to pay them. So I'm gonna chat with Joel to see what's the best way to do this.
I mean, I'm pretty sure that next year's chief will just be happy to have some academic half-day scheduled by us. They'll just be proud.
Yeah. It'd be a good day.
Well,
So do you have any social?
Especially now that the lectures are recorded, what is great, we can just forward that before we have the actual session.
Sure, it's true.
Do you guys have any idea when we are going to start in-person rounds?
We wish. We asked a question a few times, and whenever we thought we were going to start in person, then something else happened. So we kind of settled on Zoom for now. And I'm assuming that in about a month, things should loosen up and we could try to plan a few things by in person.
I mean, if the Bell Center can allow 50% attendance, that's 10,000 people, even though I doubt there are going to be 10,000 people who want to watch this garbage. You can
I'll take tickets if anyone's
imagine that
giving
you
them
can
away.
have at least 30 people in a room. I don't know.
But we
As
like
much as I love the technology, nothing beats in-person teaching and in-person.
The plan was actually last month. Like in November, we had the initial goal of, I think it was like January 16th. Like we actually set that date as the date that we were going to try to do in person, and then all this happened. So, but I do think, I think we're close. Like Anso said, I think about a month away. I hope.
With muffins.
Yeah, with muffins included. Yeah.
Thanks, Laurie.
I miss rounds. I miss seeing people.
Yeah, we have to. It was discussed at town hall this year how we have to strike the right balance. There definitely still are pluses to having Zoom rounds. It allowed us to have more outside speakers, and anyways, we're all aware of that. But we'd like to aim to have at least once a month in person, at least, to maintain the social component and still have both.
Yeah.
It's 9:01. Jake, would you be maybe wait like 2-3 minutes because people are still logging in aggressively?
I tend to give them 3-minute leeway, and then that's but we can do 2 as well.
Laurie presenting first,
yeah, I
so
know.
that means
So
you only
we're
get
already,
a minute.
Yeah,
Very patient.
We're at 9:02 right now, so we could.
No, we'll wait. It's not a super long presentation. We'll be okay. Oh,
and honestly, I'm still aggressively letting people in.
But yeah, Joel, if you have extra Habs tickets, please just it's fine. You don't have to go. I'll go.
Shred them.
We don't want you to have to look at this garbage. It's really for you.
Yeah. Okay. I'll consider it. But to be honest with you, it's been the best year to have a pandemic, because that way I don't have to pay for any of these tickets where there are no fans anyway. So I get reimbursed. So the Canadians are paying me not to watch garbage.
They're doing you a favor, really. Yeah.
Yeah.
Laurie, if it's 9:03 and we have 34 people logged in, I'll keep letting them in and we could get started.
Like now or like in a minute?
It can be now, but I just wanted to once again thank the ultrasound team who very nicely adjusted to what was planned and is always there to provide good and relevant content for us, and we really appreciate it. So
it's our
Laurie,
pleasure, but wait before you say it's relevant. So honestly, guys, I'm very happy. I know it's it could have been better. We could have been practicing today, but at least we get through the theory, which I think is very important. You need to have a good base before you go and proceed with nerve block. So hopefully by the end of today, we're going to be able to discuss nerve blocks, but also the other very important and helpful ultrasound guided procedure in Emerge. The ultrasound guided nerve block basic introduction, you can pretty much take some of these components and take it for the pericardiocentesis, arthrocentesis. Some of them concepts are very similar. So let's start right away with introduction to ultrasound guided nerve blocks. And by the end of all the presentations, we'll have a short period, and feel free to ask any question you may have. It's going to be our pleasure to answer. We have a really nice panel of experts today. So let's get going. I don't have any conflict of interest to declare. And okay, why nerve blocks? I really want you guys to think about nerve blocks for the treatment of acute pain. You know, we were always thinking about, you know, the Tylenol, Advil, and maybe some opioids for the treatment of acute pain. But nerve blocks are really practical and really good to treat some of the most difficult to treat fractures, like a femur fracture, for example, some complex burns where honestly opioids have their limitation. But also, let's say amputation. I'm thinking here about the classic snowplower injuries where people try to remove the ice and then they get multiple amputations. Nerve blocks are phenomenal for these. Think about it also as an alternative to procedural sedation. For, let's say, this very distal foreign body removal in a hand or a foot, you don't need to put these patients to sleep. You can do a tailored nerve block that's really going to help you. Complex laceration, think about it, because at one point you're going to put way too much lidocaine for those very long and very complex laceration for I don't know, a calf, for example. Nerve blocks, well, you will decrease your local anesthetic use, so it's going to be safer. Also think about it for patients with multiple comorbidities where you don't really want to put them to sleep. Procedural sedation is too high risk for them. And finally, it could just be an adjunct to your conventional PO or IV analgesia. And here I'm really thinking about hip fracture, for example. So nerve blocks are phenomenal. Think about it for all these reasons. There's literature supporting this, and literature supporting the use of ultrasound for nerve blocks. You know, we talk about nerve blocks, but here today we really want to focus about ultrasound guidance for nerve blocks. So there's a lot of literature saying that it's feasible, but it's also better than doing it landmark. But then I see your face. Okay, well, how am I going to integrate that in our practice? It takes forever, and I'm not really comfortable with it. You're an expert, right? So you talk about it like it's easy. Well, I was a junior resident at one point, and I had no clue how to use ultrasound, to be honest. So it's normal initially that you feel, you know, that you don't know things. And it's normal because we do have very little teaching on nerve block baseline. We have very limited clinical exposure. It's not like you do one once a shift. And honestly, I was really afraid of causing a cardiac arrest from local anesthetic toxicity. I was like, that's it. For sure, I'm going to put it in the artery and my patient's going to die. So I'm sure like many of you, you're not super comfortable doing nerve blocks in the emergency department. But you know what? Ultrasound is the key. Ultrasound, it will really help you try to empower you to be comfortable using nerve block because you do see where you're going. And at least you have the perception that you're going to have an increased success for your block. So take that in mind that even though we all start somewhere, okay? And today is a new day for you. I really want you to say, I can do this. Think about ultrasound also as being a safety thing, right? You're going to have less complications with your injection. You're going to have much less local anesthesia required than if you do it blind. You're going to be more successful. And you're going to have an improved quality of your block, performance time, and onset of action. Okay, now you're super excited. How do we do this? Let's talk about the basics. So the basics, the first thing is you really have to choose the right patient. Who's the right patient? The right patient is actually the patient who's cooperative, who has pain or needs procedural sedation. The patient who's not a good choice is the patient who has altered mental status. Why? It's because he's not going to be able to tell you if you are injecting directly in the nerve, so creating paresthesias. You don't want to do a nerve block in the site of a fracture, for example, where there's a risk of compartment syndrome. I'm going to give this example, a complex tibial and fibular fracture with a lot of swelling. Don't go and do a sciatic nerve block at the level of the popliteal fossa. You know what? You're just going to, we know that these fractures have a high risk of compartment syndrome. Putting extra fluid there might not be the best idea. Patients with an acute neurological deficit, again, just because you won't be able to monitor the neurological deficit and you won't really know if it's your block versus the fracture that's causing this, like for example, in a compartment syndrome. Local anesthetic allergy, of course, that's a no-brainer. Infection at the site of the injection, don't go there. Coagulopathy, I'm going to put a little asterisk. I would say that for those who have, if you're good, you know where you're going, it is not a full contraindication. It's a relative contraindication. Usually when I'm going to look is when did they last receive, for example, their Eliquis. And then let's say it's been 12 hours, I'm going to go and do it because the benefit of doing, let's say, a femoral nerve block for a hip fracture outweighs the risk of maybe me causing a massive hematoma at that site, especially if I'm careful, experienced, and I'm using ultrasound guidance. So take it with a grain of salt. So maybe not always a contraindication. Okay, the basics, nerve block selection. This is very important. When you decide to choose a nerve block, I don't know, I have a wrist fracture or a finger amputation after a snowplower injury. You're going to have to decide, okay, where do I perform my block? If you do, for example, an interscalene nerve block, it's going to give you a beautiful anesthesia of your arm. However, every proximal block is associated with more complication. An interscalene nerve block, for example, where first of all, you're really close to the carotid artery, so there is an increased risk, but you can have phrenic nerve palsy, for example, from it. So maybe not the best choice if you can do, for example, a median and a radial nerve block proximally, distally, where you really have a low risk of any vascular puncture or definitely no risk of affecting the respiratory system. So always try to choose the most distal block possible for your injury. That's tough to know, right? Well, how do I know? How do I remember the types of block that could be used, for example, for an arm laceration or burn? Okay, I want you to go right now on your phone, download this free application that's called Nerve Block. It's extremely well designed where you can just click on the anatomy, what you're looking for, an arm, a leg, a torso, a neck. And then it's going to give you the type of blocks you should be going. So see on the screen now, it says digital. Sometimes you just need a digital nerve block. You don't need to go and do a medial nerve block, for example. Or actually, maybe the nerve block is a median nerve block is not going to be appropriate for the type of laceration that you have, let's say, on the third finger. So very useful application. Download it now so you have it in hand whenever you consider doing some sort of a block. Probe selection, oh, that's an easy. Probe selection, you always want to choose the linear preset. If you have a high frequency or super high frequency linear preset, that's even better. But otherwise, the typical linear preset we have in the emergency department is just fine. Why do we use this? It's because it's going to give you a high definition. This is really what you want because the nerves is not always easy to see. So linear probe, and make sure here that you use the presets. I don't think we talk about it enough when we talk about ultrasound. The presets are important. They are made for you to better visualize the appropriate structure, being the uterus, the heart, and here, the nerve. So you want to select the nerve preset. Okay, let's discuss some sonoanatomy. The nerves look like honeycomb. You know the cereal, or no, the honeycomb from bees. It really looks like a hyperechoic network with small black or hypoechoic bundles. And these are this will basically create the nerve. So here we have a nice example of the ulnar nerve here on the screen that looks like a mini honeycomb. It is often triangular in shape and very often, except let's say maybe the median nerve, it's going to be associated with a vascular bundle. That's typically how I'm going to tell residents, try to find the radial artery, the ulnar artery, and it's going to be right next to it. The triangular shape that's really going to abut the artery, especially at the level of the distal wrist. This is really how you're going to find it. A little pearl, because I know you're going to say, yeah, it looks really easy, Laurie, but I do have trouble finding the nerve very often. Optimize your image. See the image on the screen here. I'm wasting some screen. The depth is too much. You really want to decrease your depth to really try to focus where the nerve would be. And the nerve here is really on top of the screen. This is actually the sciatic nerve dividing in its two different nerves right here. Use the nerve preset, again, very important. It's going to help you visualize this honeycomb-like structure. And here, beware of anisotropy. Anisotropy is whenever you try to hit a structure, but you're not hitting it completely perpendicular. It's going to look fuzzy. You won't have a nice definition. Really what you want to do, always try to make sure your probe is perpendicular to the nerve or to whatever structure you're looking at. But in this case here, a nerve. That's one of the most common pitfalls I found. Also make sure this is not a blood vessel. Sometimes it's going to look, bizarre, or you might have a blood vessel really, really close to the nerve of interest. So make sure you always activate Doppler to make sure that you're actually not going through the path of an artery or a vein if you're trying to get to your nerve. So these are small pearls. That's pretty much it for the sonoanatomy. Okay, let's talk about the choice of local anesthetic. I would say that for most of us, the number one choice should be lidocaine. Lidocaine is very safe, so it has a great safety record. You know, when we talk about local anesthetic systemic toxicity, all reports were basically described with the use of bupivacaine or some of the other agents, but lidocaine, no, because it's something that we know how to use. Fast onset, great safety record. You can use 1 or 2%. Agent of choice for most of your ultrasound guided nerve blocks in the emergency department, especially when you're starting. The number 2, I would say, is bupivacaine, and that's what we most commonly have in our emergency departments. There's also ropivacaine. I do have ropivacaine in Valleyfield. It's actually safer, but it's not available everywhere. So let's go with bupivacaine. Here you have to be very careful because it comes in 2 concentration, 0.25 and 0.5%. Up for the 0.25, because again, you're going to be able to put a little bit more liquid, safer profile when you use lower concentration. Keep in mind, it's going to have a slower onset, but it's going to last longer. So for those hip fractures, it's actually probably the agent of choice. There is a risk of local anesthetic toxicity. Keep that in mind. So I would say it's your second choice for ultrasound, most of your ultrasound guided nerve blocks in the emergency department. Okay, and then what about lidocaine or bupivacaine with or without epi? In theory, the use of epinephrine is really going to increase the duration of action, and you're going to be able to use more of your local anesthetic because of epi. And remotely, it was used as a marker for intravascular injection. So your patient is on the monitor, you're doing a blind nerve block, or let's say a partially guided nerve block, and all of a sudden the patient becomes tachycardic. Well, perhaps you're injecting in the artery. I would say that this is not something super reliable. I would say that the theory is just that in theory, it's going to increase your duration of action and dose of local anesthetic. In practice, I don't really use it. We can ask maybe the other POCUS expert after, because there's no strong evidence that all of this is actually happening with epinephrine. And there is a potential microvascular nerve damage because around the nerve, there's a sheet that really supplies all the nutrient in the blood to the nerve. And with this vasoconstrictive effect of epinephrine, in theory, you could be injuring the nerve. Again, this is all theory, but I do in my practice not use epinephrine. I just use plain lidocaine or plain bupivacaine. Okay, I've been mentioning this term a few times now. Local anesthetic systemic toxicity. What do we need to know about this? And then if we have any toxicology expert in the audience, I'm sorry. And if I'm wrong, please let me know, because I know it is open for debate. But local anesthetic systemic toxicity, I would say that you have to be ready for it. If you are not ready for it, do not perform a block. What you need to know is, where are your intralipids? So how do we treat local anesthetic systemic toxicity? So typically it's going to present with cardiovascular collapse, neuro symptoms, seizure. You absolutely want to make sure that you put your patient into resus, you treat the seizure, you make sure that you're giving the appropriate medication. But intralipids is actually the antidote of choice for those local anesthetic systemic toxicity that are going into arrest. In theory, for a block, you want to be having your patient on a cardiac monitor with pulse oximetry, and you want to have IV access. But what about the distal block, like an ulnar nerve block? I'm not going to start putting my patient on cardiac monitor, get him an IV just for this. General rule, all the blocks that are below the elbow and below the knee, you don't need to put the patient on cardiac monitoring. Why? It's because you're aiming for smaller nerves with a very small amount of lidocaine or bupivacaine. So this is extremely unlikely that you're going to have a local anesthetic systemic toxicity. For everything that is above the knee or above the elbow, I would say that you should at least put the patient on pulse oximetry if it's not a full cardiac monitoring. The pulse oximetry is going to be able to monitor your saturation, but also your heart rate. That's my practice. So for femoral nerve block, I make sure that my patient has pulse oximetry, and most of the time they will have an IV access. Very good. So that's how you get ready for local anesthetic toxicity. And no, you don't need to put everyone on a cardiac monitor. That's really cool. That's a trick of the trade. So that's one of the, I think it's called Pussy Verbis PDF cards that was designed by Michelle Lin. Super cool. So it's like a nomogram that you can use that you should have on your phone. And then what you do is you choose, first of all, your agent. So let's say I'm going to use a lidocaine 1%. Where's lidocaine 1%? It's right here. Lidocaine 1%. And then I'm going to say my patient weighs, 60 kilogram. I'm going to draw the line. And then where it crossed the max volume is going to give me the max volume of local anesthetic that I should be using for this particular patient with this particular agent. So that's really cool because I don't have a lot of time, and very often I'm like, oh my God, what's the dose again? The toxic dose, the milliliter, and then you don't want to make a mistake, right? So this will give you a quick approach to calculating the max local anesthetic dose that you want to administer to your patient for the block. So really cool, and it has pretty much all the agent that we can be using in the emergency department. Similarly, there's also an intralipid local anesthetic toxicity little nomogram where, let's say your patient, let's say knock on wood, starts seizing, cardiovascular collapse. You go get your intralipid, you're going to calculate the weight. So let's say your patient, we said 60 kilogram, and you're just going to draw a line all the way down. So your initial bolus is going to be 90 cc's of intralipid, and then you're going to start it on infusion. I think the infusion is very debatable, but at least the initial lipid administration. So these little things I'm going to send you via PDF whenever we do the summary of the lectures, okay? So you have access to them. Okay, so now that we know basically how to recognize a nerve, how to make sure that we're using the right local anesthetic and to take care of the complication, how do we set up? Setting up is extremely important. You have to make yourself comfortable. Don't do a nerve block all crooked, sitting up in a weird position, because it's going to take you a little bit of time and you really want to optimize everything. So that was actually one of the procedure day that we did at the Sim Center when I think first year of staff or whatnot. So see, I am sitting with my probe in front of me and my machine in front of me. So I don't have to do any head motion where it's going to be difficult and I'm going to not really be able to see my target. This is the perfect setup. You also notice that my legs are crossed. This is extra point for style, and it's very important that you do that for any of your nerve blocks. No joke, the setting is very important. What do you need in terms of equipment? So equipment, I would say, if you want to be efficient in your emergency department, you want to be running all around, have some pre-prepared kits. So a kit where you're going to have everything. So this is the Joel's femoral nerve or fascia Iliaca block, what he created for us at JGH, or maybe, is it JGH? I think it's JGH. Where you really have everything inside. So gauze, needles for like the initial puncture. You have the needles for the big puncture. You're going to have some NS, some cleaning material, and some little towels. So very useful to have something already prepared where you're really going to have everything. If you decide to do a block and you're not super comfortable, the other thing that you can be using is extension tubing and an assistant. So instead of going directly with your needle and your syringe, you have an extension tubing that you connect to your syringe. So the only thing you're going to be manipulating are the probe and the needle. It gives you a lot more freedom. It's less cumbersome, while the other person is going to be there to inject when you ask him or her to do so. Last little trick, if ever someone is interested, I have a million of them in my office, it's controlled syringe, just like at the dentist. It's actually easier to aspirate and to inject for those with very small hands, or when you're not super comfortable doing them. They're single use, so but it's fun. You don't do nerve blocks all the time, and it's actually fun to have the feeling of really being able to inject in a controlled way. So controlled syringe, if you're interested, just let me know and I'll give you one for free. Okay, so in terms of needle selection, this is important. You want to be using a needle that's actually sturdy enough that it's not going to bend in a soft tissue, and that's going to be big enough so you're going to be able to see it with your probe. If you're using, I don't know, 25 gauge, you know, the blue needle, the 25 gauge, it's so thin that you're going to have trouble seeing it under your probe. So maybe not the best choice. Also, whenever you're going to enter the tissue, it's going to deform, it's going to be difficult. I would say that most of my distal nerve block, I'm going to use a 22 gauge, so the gray one. regular needle, because it's really going to give me a good visualization, but also it's sturdy enough that it's not going to bend when I go into the soft tissue. For any big blocks, a sciatic nerve block, femoral nerve block, the erector spinae block that Joel's going to talk about, I would strongly suggest you use a spinal needle. Why? The length, because your target is further away, but also it's thicker. So it's really going to give you a nicer visualization of the needle under your ultrasound probe. What you do is you take the 20 gauge is the yellow one. You're going to remove the stylet, and you're going to be using the needle to screw it on your extension tubing or directly on your syringe. And here you are ready to go. I use this technique to sterilize my probe because in theory it's a semi-sterile procedure. You're going to be using your probe, a medium-sized tegaderm, something to clean the skin, and then some muco, which is in theory sterile gel, instead of using the sterile envelope we have for central lines. Here is my probe covered with the medium-sized tegaderm. And that's pretty much it. And then you would be good to go. That's pretty much all you need in terms of setting up for the block or the equipment that you need for protection, but also for your nerve block. I want to briefly talk about technique. There's two techniques. You're going to either go in plane or out of plane. The number one technique I would say for most blocks we do in the emergency department are in plane. Why? Look at how nice this is. I'm going to replay the video. I can see my needle. This is actually a medial nerve block, okay? So this is probably the maybe ulnar artery. This is the medial nerve, and I am, see my needle is coming close to the nerve. I see it so well. So the incline approach will really help you get your needle right where you want it to be. The other plane is a good one. Let's say you don't have a lot of space. And here is a perfect example of a posterior tibial nerve block. This is the posterior tibial artery. This is the posterior tibial nerve. And here I'm coming down with my needle straight, well, not me, the person who gave me that video, Mike Stone, all the way down. And I am going to go and aim to put my needle tip. Oh, see, the needle tip is actually right here. But in theory, I want to aim to go closer to the nerve right here. I'm not going to see my needle well, but at least I'm going to see the local anesthetic whenever I inject it. Oh, see, now I do see the needle tip and I'm going to inject. We're going to talk about it, but that's called hydrodissecting. So I'm dissecting the tissue with either water or NS or the local anesthetic to really see where am I, or am I close? Where am I injecting? That's called the hydrodissection technique. Okay, it's a little bit more complicated to do this type of block, the out of plane block. But once you become good, it is a good, very good technique when you have limited space, like in this case. Okay, Pearl, make sure that you enter with your needle completely parallel to the probe. And here I hope that you can see me. This is my probe, this is my needle. Most of us, we enter with an angle, like 45-degree angle. What's gonna happen, you're not gonna see your needle as clearly. Like in this example, in this video, I am really entering completely parallel to my probe. See, that will make your needle have a lot more what we call the ring down artifact. So all these lines that are ringing down, and you can actually see my bevel so well. So that's really, you want to make sure you enter parallel to the probe. How you do that? Often you're gonna have to enter below your probe. You know, we always want to enter right at the probe, but what you do is you say, okay, well, my target is about 1 centimeter below the skin. So what I'm going to do is I'm going to enter with my needle 1 centimeter below my probe. So that way, when I enter with my needle, it's going to enter on the screen 1 centimeter below the probe, and you're really going to be able to aim for that target. That's very, very important. That's an example where I'm actually entering with an angle, and you can see how the needle, you see much less clearly. At least the tip, okay, you still see it well. It's not a crazy angle, but the definition is definitely less than on the previous video. That's another example here where I'm just going to readjust. There you go. I am entering with, some angle, but I'm still quite parallel to my probe, and you can see the needle very well. Actually, that's an example where my needle was very, very thin. That's probably a 25 gauge. Look how tough this is for me to try to find it. It's really, really a fine needle. So again, try to use a slightly bigger gauge to be able to visualize it better. The hydrodissection technique, I was talking about it earlier. So this is my needle here on the left of the screen. And then what I'm going to do, I'm going to inject a little bit and see, oh, you're going to start seeing local anesthetic that's going to be there very soon. Oh, I am slowly injecting just to see where am I in terms of, it's kind of helping you localize your needle or where you're at when you're having trouble seeing your needle. So hydrodissection, you can decide to use it with the lidocaine like you have in your syringe. So for example, on ulnar nerve block, I'm going to draw 10 cc. If I get close to the nerve, I'm probably just going to inject 5 to 7. The extra 2 or 3 are just for me to help with hydrodissect if ever I'm having trouble seeing the tip of my needle or if I want to get closer to the nerve. Okay, that's a good trick also. Try to inject around the nerve and not in it. And how do you know you're going to inject in the nerve? Let me tell you, the patient's going to tell you. The patient's going to experience paresthesias or like sharp electric shock going through his fingers, for example, in this case where it's a distal block, or in the leg, for example, for a femoral nerve block, if you poke the nerve. And here you can see that I'm approaching. I think I'm at the right place, but then I hit it right there. The patient's going to tell you. And then when that happens, you just withdraw a little bit and you continue slowly injecting. If you inject in the nerve, the other thing you're going to find is some resistance. Well, if you inject really around the nerve, you're not going to have any resistance. So careful not to inject in the nerve. Make sure that you try to surround the nerve. So this is exactly the same block that we were doing where I was actually poking the nerve. And here we have the artery, the nerve, and local anesthetic surrounding all my nerve. So you don't need to go above, middle, and below. But if you are able to do so because you've entered super parallel to your probe and you can just readjust very slightly like this to be able to surround the nerve, it's really going to give you a beautiful result and a beautiful nerve block. Again, if you're not super experienced or for bigger blocks where you need a bigger syringe with more local anesthetic, don't hesitate to ask for a friend or an assistant to help you and do a two-person technique like illustrated here for a sciatic nerve block, where you have really only your needle to control. Okay, how do I get efficient with this? Because it's all good in theory, but my practice, I see a lot of patients, it's very busy. I don't have time to do this. Yes, you do have time to do this and it's good for your patient. And some little tips that you can use to make sure that you become efficient is, again, nerve block kit. This is very, very, very useful. Have an algorithm or nomogram to calculate your local anesthetic dose. It's really going to save you some time. And have an official protocol where you just have tick box that you've done the block, the safety measure. It's really going to help you become a lot more efficient and have a safe way to do nerve blocks in your emergency department. The last thing is practice. You really want to try to practice. When you're a resident, you're not here to do flow. Okay, yes, you do have to do flow. And at one point, as a senior, I'm expecting you to do flow. But I would say if you do have the chance to do a nerve block, you really want to take it and do it. Because when you become a staff, it's a lot more difficult to do these things. So take the opportunity in the sim days that we're going to be making for you, hopefully when COVID is out of the picture. But also during shift, make sure you practice. The more you do, the more comfortable you will become. And then the rest, let's say you've never done an interscaling block. Well, you're going to be comfortable doing it if you've done a ton of other blocks because it's all the same principle. So practice, 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 it's key. Okay, now you're super excited. You think you have enough baggage to be doing nerve blocks in the emergency department. I think you are ready to do so. And I am very happy that now we're going to be talking about 2 specific blocks that are really cool and very useful that are going to be presented by Joel. And then for the rest of the day, we're going to have crazy presenters on very nice procedure. Any questions at this time? If not, and you think about it, about nerve blocks, another question, we'll have a question period at the end, like I said initially. Thank you very much. And I'm going to stop sharing my screen and answer any questions you may have.
Merci, Laurie. Actually, I have a question. When you say you want to enter, let's say that your target is 1 centimeter below the probe and you want to enter parallel, do you have a rule of thumb of where you enter the skin, about the same length, or?
Yeah, so it's tough to explain, but let's say on my wrist, you put the probe here, and then you say the nerve on the screen is actually a centimeter below the probe. So what I'm going to do is, instead of entering right below the probe, I'm going to enter, oh, right there, a centimeter below my skin, for example. Now there's bone, but in theory, you won't have bone. So you really want to, it's okay if you don't enter directly below the probe, that you enter here. You won't see it initially, but then as soon as you hit your probe, oh, now you're going to start seeing it. You can do that for femoral nerve block. You just have a bit more soft tissue to go through. As long as you don't have vital structure, like in that first part of the area where you're going to poke. But this is the number one trick I find that's really going to help you visualize your needle better and make you a lot more confident as to where you're going.
And Sophie, can I just make one or two quick comments or notes just to add? So, so great lecture, Laurie. Just remember, because this is going to be important for the talks that I will be giving, there are two basic types of blocks. There are direct nerve blocks, such as what Laurie was talking about, so the ulnar nerve block or a posterior tibial, where you're injecting small volumes right at the nerve. And then there are fascia blocks, which are going to be ones that I'll be talking about, where you're injecting actually large volumes in the fascia near the nerve that you're going to be, or surrounding the nerve that you're going to want to anesthetize. The main difference is that for the nerve blocks, they're small volumes that you can use your control syringes, but for the fascial blocks, which I'll talk about in a second, there's very large volumes, 20, 30, 40 cc's of fluid that you're injecting. So there's a different kind of philosophy, and you can't really use the control syringes for that. But the control syringes are fantastic when you want to do a very simple, elegant little nerve block, like doing an ulnar nerve block or a radial nerve block.
That's an excellent point. I'm going to add that in my presentation. It's true. It's a different, same technique, but different type of local anesthetic use in those.
And there's a question from John Guy. Your nomogram for local anesthetic shows bupivacaine is less toxic than Lido, but you said the opposite at the start.
Yeah, so it's it's because you can use more, especially for 2% lidocaine, but all the case reports of last, they were with bupivacaine. So it seems that it's actually more toxic when you go intra-arterial than xylocaine. So that's pretty much what I would say. But the other thing is we're way more used to be using lidocaine in terms of calculating the toxic dose whenever we do the typical digital nerve block or laceration repair. So I think that has to play with it also.
So just to emphasize as well, is really because the bupivacaine will last a long period of time. So if you need to add bigger volumes, there's going to be an additive effect to your medication. Lidocaine short acting, that the risk of toxicity overall is less. Maybe you can lose a bit, you can use less volume than the bupivacaine, but just the length of action of bupivacaine makes it a higher risk medication.
Yeah, it's just that I used for digital blocks, I got used to using bupivacaine because it lasts longer. So the patient gets more analgesia after. So I got used to the amounts and that. So
that's
the duration is better.
Completely agree. And then with digital nerve block, for example, the volume is minimal no matter what you do. So I think both choices are good. It's just to keep in mind whenever you do larger blocks, or as Paul said, maybe blocks where you would have to add some more. That would be definitely a consideration there, but very good point.
Great, thank you. I think Dr. Turner, the floor is yours.
Okay, let's share the screen. Everybody see the screen? Good. All right. As Laurie said, it's unfortunate that we couldn't do this in person because I think nerve blocks are such a cool additive use of our POCUS skills in the emerge, and I think it is becoming more and more an essential skill for us in the emerge. So I'm going to be talking about two fascia blocks. One, the fascia iliaca block for hip fractures, and then the second talk will be on what's a new block, which is not well known, and that's the ESP block. So we're going to start with the one which I think is critically important, and that is the fascia iliaca block for patients who come in with hip fractures. As Laurie had brought up a great resource on your phone, I would echo that by having everybody follow and subscribe to the New York Society of Regional Anesthesia on YouTube. They have amazing free videos. Their website and their app for your phone also has fantastic anatomy and diagrams to explain everything you want to know about anesthetics and nerve blocks. So it's a fantastic resource, and for everything on YouTube is obviously free. Just to remember, Anne-Sophie or Jake, whatever, if there are questions, please just wave your hand, because I may not be able to see on the chat that there are questions for me. Okay, so first case, we see this every single day. Of course, we're going to see this all the time in the winter. We have a frail old lady who comes in after a fall. Her leg is externally rotated and shortened, and as you surmise, she's got a pretty bad intertrochanteric fracture. She's 91, and you prescribe your usual, your morphine, your Dilaudid, but you give minuscule doses because you don't want to have her go into respiratory arrest, or you don't feel that there's a risk, so you give her regular doses, but you know that you are not providing adequate analgesia for this patient. And there is a far better and far safer method to provide analgesias for all these patients who come in with hip fractures. And the literature is very, very strong in establishing that. So when you will look, first you'll talk about, or you'll see in the literature talking about ultrasound guided femoral nerve block, which is a fantastic block. But what I want to expand on is what I feel is an easier nerve block and is actually better. And that's what's called the fascia iliaca block. And we'll explain why exactly. So as I mentioned, this is something that all emergency physicians should know, because we all see hip fractures and we all see elderly with hip fractures. And the literature is very clear that there's much better pain control. There are far fewer complications. There's less delirium in the elderly patient, and there is significantly decreased use of narcotics in the emerge and also on the floor. And you should consider this for all femoral, neck, intertroch, and midshaft hip fractures. Why? So this is just a quick review. So all these fractures here will be analgesed by a good fascia iliaca block. The only area that may not work so well are the subcapital fractures, because that area is somewhat innervated by the sciatic nerve or a branch of the sciatic nerve, so you may not get good analgesia at the very, very tip, but anything below that is fair game for a fascia iliaca block. So why is that? Well, there are three nerves that innervate the proximal femur. Obviously, the femoral nerve is the major nerve that goes from the femoral head all the way down to the mid shaft. However, you also have the obturator nerve that innervates the more medial aspect, as well as the lateral femoral cutaneous nerve, which is on the greater trochanter. So all those three blocks play a role in, all those three nerves play a role in pain control for your analgesia. So where do these occur sort of anatomically? Well, you've got your lateral femoral cutaneous, which is way out lateral. You've got your primary femoral nerve, and then your obturator nerve, which is more deep to your inguinal canal or inguinal ligament. So how do you do a fascia iliaca block? So as Laurie had mentioned, I cannot stress this enough. If you realize that you have to go and get sterile towels, Tegaderms, muco, syringes, and needles every time you want to do a block, any block, you're never going to want to do it. So we have a sort of grab and go kit in our department in the yellow unit. all you need is your sterile wipes, your cleaning solution, and your analgesia, and you're good to go. You're ready to do your block. So try to make these in each of your departments to make it easier for you to start doing your procedure. Again, like Laurie said, it's very important that you have your machine on the other side of the patient, that after you have set it up, you don't have to twist your head or your neck, and your view is directly in front of you. So it increases your ability or your success rate. So you're going to be using a linear probe, just like what we would be doing for looking for a DVT. So you're going to be high in the inguinal crease, and you want to first identify your most identifiable structures, and that's going to be your femoral artery, which is going to be more medial on your probe. Just lateral to your femoral artery will be a triangular femoral nerve, which I'll show you what it looks like. And then what you'll notice is right in front or proximal to the femoral nerve will be a white connective tissue fascia, which is the fascia iliaca. And just above it, more superficial, will be the fascia lata. Why do I call or identify these two? Because traditionally, when people were doing without ultrasound guidance, you were always being taught to feel two little pops before you get to your femoral nerve. Well, those two pops are the nerves traversing first the fascia lata and then the fascia iliaca on the way to your femoral nerve. So what does that look like on ultrasound? Well, you clearly will see your femoral artery, and then just lateral will be a triangular femoral nerve, which will be quite pronounced when you see it on your screen. Just lateral to your femoral nerve, this white echogenic connective tissue structure, that's your fascia iliaca. And just above that, superficially, is your fascia lata. So you can recognize if you're going to come in from the skin surface, you're going to feel one pop and two pops to get into the space where you want to inject. Just distal will be your iliacus muscle, and you'll see very clearly, sort of anatomically, what muscle looks like. Now, as Laurie mentioned, anisotropy is very, very important to be able to easily visualize your nerve. If you can see, this is a nerve in the near field. I don't know if you see my my little cursor there. So as I am going to be tilting my probe back and forth, you'll see how the nerve disappears. You can barely see it, and then becomes very, very echogenic. So by going back and forth and finding the perfect angle, you'll be able to see your femoral nerve very, very clearly. So once you find your femoral artery and femoral nerve, remember, you're not injecting the nerve. You're going to be injecting lateral to your nerve, a couple centimeters away. So you're going to want to slide your probe lateral and just keep your nerve on screen right, and just visualizing this fascia iliaca, because that is where you're going to want to inject your block. So you're going to be a good 1 to 2 centimeters away from any nerves, any vessels. So it's a very safe block. And that's another reason why I like to teach that instead of the femoral nerve block. So it's an in-plane approach. You're going to be injecting with your needle entering from lateral to medial. And again, you're going to be doing a fascial block. So therefore, volume is your friend. You want a large amount of volume, so about 20 cc. So the traditional recipe is you'd use 20 cc's of 0.25% bupivacaine, and then you'll add more sterile saline for a total volume of about 30 to 40 cc's. So it's important that you get volume injected into the fascia and not necessarily the concentration of your analgesia. So this is basically what it looks like. If you see your artery, your nerve, which is the triangular structure right here, and then your fascia iliaca, you're going to be coming from screen left and basically entering right here. You'll see the needle, and then you inject, or you have your colleague inject when you want. As you follow it along, you do some hydrodissection and you inject a little bit more. Now, I may play this again, but look how, as you're injecting the volume, that the fascia actually collapses when you stop injecting. I want to just play that again. Hopefully I can be able to do that. So as you're injecting, you can see it's flowing in there. You inject, it spreads, and then when you stop injecting for a little bit because you want to reposition your nerve, it actually collapses. This is actually a very good sign that you're in the fascia and that the fluid is actually spreading along the fascia as it's supposed to, and that's why it kind of collapses on itself. If you're injecting and there's a bulge of black and it doesn't move, and especially if there's some resistance, you're either too deep into the iliacus muscle or you're too superficial, and then you have to reposition. So it's a very good sign that when you inject, the black kind of spreads out. When you stop injecting, the fascia kind of collapses on itself. It shows that you've got a good, you're in a good position. Just now, when you inject your 30 to 40 cc's, that will spread and provide very good analgesia for the femoral nerve, which is the area that you're looking at, the obturator nerve, which is more distal, as well as the lateral femoral cutaneous, which is more lateral. But because you're putting so much volume, 40, 30, 40 cc's, all three nerves will be affected and will give a very, very good block for your femoral fractures. Just remember that you have to make the patients aware that they may paralyze the affected leg. So make sure the nurses are made aware, the patients are made aware, and especially the orthopedic service is aware that you've done this procedure so that the nurses on the floor or the residents on the floor are aware of assessing for pain and movement. And what we have inside each of our femoral nerve block kits is an information sheet that the nurses take to assess neurovascular status and to provide information for the nurses in the emerge, as well as for the nurses on the orthopedic floor. Make sure you know what your maximum dose of your local anesthetic is. Since we're using bupivacaine, we see that the maximum dose is 2 milligrams per kilogram. So if you just remember, in a, let's say, 60 kilogram person, that's going to be 120 milligrams. But we're well below the maximum dose if I'm just using 20 cc's, which is only 50 milligrams. So you're well below the maximal dose of toxicity in using bupivacaine. So there is no real concern. Just make sure you're using the 0.25% solution and not the 0.5% solution, because obviously that will double your concentration. We talked about last, so when you're doing a block like this, which is going to be close to some vascular structures, you want to make sure they're on a cardiac monitor or at least on a pulse oximetry, so you can detect right away some cardiovascular reactions. And just be aware, where is your ED stock of intralipid? This is not something you want to start looking for after the fact. You want to know, is it in the emerge? Is it in pharmacy? Just know where your ED stocks are intralipid in case. All right, obviously, when you're doing an inline approach, it's a little bit easier, but you still must be able to visualize your needle tip at all times. You want to make sure you're not going too deep. You want to make sure you're not going into the nerve, even though you're staying far away from this nerve and you're going into the fascia. So I think this is a block that everybody should be using. It should be standard of practice. It provides so much better analgesics for hip fractures than just giving your usual narcotics. And it's a far safer procedure than, again, giving narcotics to your patients. And basically should be sort of standard of care for everybody comes in for hip fractures. All right, any questions from the audience? As I mentioned, resource for there.
There's something trending where people are asking to have the list of the kits you guys have at the Jewish, because to my knowledge, and please correct me, but I don't think they're available anywhere else. So I think that'd be great.
Yeah. So maybe in the I will send out with your summary next week. I'll send out our list of our. It started out as a femoral nerve block kit list, but this should be available for all nerve blocks. So I'll send that out as to what you should do, and you should have your stocking people, whoever does it, make sure that they're restocked. So whenever we're running out, we make sure that we have plenty of it available in the emerge, so we don't have to, again, create them when we need them.
Great. And then what is the duration of the block?
So good question. So this actually can last a good 24 hours, even though bupivacaine itself lasts less long. these patients get very, very good analgesia and reduced need for narcotics for a good 24 hours with these patients.
Jake, and then Antoine.
Yeah, so in terms of visual cues, so like as long as you know that you're in the fascial space and you see it dissecting, like, is there any other indicator besides just, like you said, volume is your friend, like 20 cc's? Like, are you looking for something beyond the dissection?
No, if you are seeing it dissect along the fascia and you'll see it go towards the femoral nerve, you're not going to see the lateral femoral cutaneous. You're not going to see the obturator. But if you see it going along that fascial plane, you're as good as gold. You inject your 30 to 40 cc's. Some people say to put your patient a bit in a bit of Trendelenburg and then maybe compress distally to make sure that the volume kind of disperses more proximal into the lumbar plexus. You know, I don't sit there and put my hand against their leg, but I may put them in a little bit of Trendelenburg just for 5-10 minutes. But no, that's it. You're in. That's your go-to indicator that this is going to be a good block.
Great, thanks.
My question is more, let's say you're in the trauma room, the patient comes in, and clinically, well, there's the rotation and stuff. Would you wait for an official read or an official image, or would you actually treat the symptom?
You know, that's a very good question. There are some people who advocate just doing the block right away. It's a question of how quickly you're going to get your X-ray anyway. If you're going to be getting your X-ray within 5 or 10 minutes, probably I'll just wait because I just want to get reassurance. Clearly, if you're working in a rural area and these have to be sent out for imaging, well, for sure, I would do the nerve block for transport. So there's a bit of a back and forth, but it's a good question. Some people do say if it's really crystal clear, walks like a duck, quacks like a duck, this is a femoral fracture, I'll inject anyway. But you know, I would like to see it on the screen before I do it.
Actually, looking at the app that Laurie told us to download, it repeats the indication that you said. So it's actually quite good. I never use it. Thank you. And Laurie, you raised your hand.
Oh, so in other words, yeah, I was right. Phew.
Yeah, aren't you happy I'm confirming you're right?
That's you. I'm glad.
Yeah, it's a good pearl. I just want to say that for clear femur fracture, don't hesitate. I remember vividly doing one in a patient who was still on an EMS stretcher because she was in horrible pain. It was grossly displaced. Just go ahead. It's going to give them complete anesthesia of the leg. It's going to help you do all the tests after. So maybe for hip, no, but for clear femur fracture, there's absolutely no contraindication if there's no contraindication to the block itself. Make sure you do a neuro exam before though.
And actually, always. John just asked the question, which is very true. Won't the ultrasound show the fracture anyway? Sure, if you're good at assessing for intertroch fractures, that sort of thing, yes, you'll see it. But intertroch and femoral necks are sometimes a little bit challenging, but femur shaft fractures, obviously you'll be able to see it on ultrasound and go ahead and do your block.
And I cannot think of one, but would there be any contraindication with other related fracture? Let's say you have an associated pelvic fracture. I don't think so, but
I can't imagine. This is a very safe. There are no, critical structures on the way to the fascia iliaca. There are no blood vessels there. As long as you can see your needle tip, you're just literally going through fascia, 2 fascial planes, and just before the iliacus muscle, and you're really not in any danger of other structures.
Any other question before we move on to the next lecture? Wow. Or if not, as Laurie said initially, we'll have a question period at the end.
Yeah.
Thank you so much. Next up is you. I was looking at the schedule.
Okay, so here is another block which probably is not as commonly used, but in terms of disposition, I don't think I have done a block where it changes a patient's disposition so quickly. And so this is something that I think is a block that should be considered as an option. So this is called the ESP block, or stands for erector spinae block or plane block for acute back pain. So this is going to be a block that has really been new over the last 5 or 6 years. So you have a guy who comes in after lifting a heavy object. He's in severe pain. He can't even move, let alone get off the stretcher. Neurovascular, he's intact, but you're giving him oral or IV narcotics. And, he's still in pain 4 hours, 6 hours later. He just can't move. He's in such massive pain from muscle spasms that you're not sure. And of course, you have to end up admitting him to a short stay admission because he really can't get off his stretcher. He's going to need to be on narcotics, analgesics, anti-inflammatories, and then, physiotherapy, that sort of thing. But there is a block that could potentially avoid an admission or a prolonged length of stay, and that is the ESP block, or the erector spinae plane block. This is a block that, like I said, is very, very new. It's only been described since 2016. It's a very good block for treatment of posterior rib fractures, which I'll give maybe 2 or 3 slides about it. If you have some vertebral compression fractures, or if you have severe pain for post-herpetic neuralgias or burns. But what has come in the emergency medicine literature is the treatment of severe muscular low back pain. So like the femoral fascia iliaca block, this is a fascial plane block, a single injection of a large volume of analgesia. So this is sort of the complex of the erector spinae muscle. So there's this whole sort of conglomeration of muscles that go all the way down to the back. And it's believed that you are providing pain control by blocking the nerves that are exiting from the spine into, and that are innervating those muscles in the back. So where you're going to be looking for, let's look at a bit of the anatomy in the back. There's your spinous process. Just lateral to it are your lamina, and lateral to that is your transverse process. And that's what's important, because that's going to be your landmark where you're going to be injecting your local analgesia. Where you're going to be injecting in that area where your erector spinae muscles are, and you're going to be injecting so that you can analgese the dorsal ramus nerves, and that is what's going to give you good analgesics. So the premise here is that you are injecting in the area just behind the transverse process. And what is happening is, because this is a volume block, you're going to be actually analgesing 2 levels below and 2 levels above the site of injection by providing analgesia in this area. So what is the technique? While the majority of all of our ultrasounds probes for nerve blocks are to use the high frequency vascular probe, sometimes you will need to use the abdominal probe if these patients have a lot of muscle mass or a lot of musculature or adipose tissue, where you're going to have to see things deeper than 5 or 6 centimeters, in which case you're going to have to use your abdominal probe. You can have your patients sitting lateral decubitus. If they're coming in, most of the time they're coming in with severe one-sided paralumbar pain. So you have the affected side up, and you're going to inject around the L3, L4 area. Now remember that you're going to be getting analgesia 2 levels below and 2 levels above. So you don't have to inject at the exact level of their muscle spasm, but if the L3, L4 is good enough. So what is the technique? First, you're going to place your probe in the midline. You're going to find your transverse process. And actually, I think Greg, who is going to talk about lumbar puncture, ultrasound-guided lumbar punctures, is going to be the sort of the same kind of things he's going to discuss. So you want to first find your transverse process. Then you're going to slide laterally where you're going to see your lamina, and then you're going to see your transverse process, and that is going to be your landmark for your injection. So this is an example of what your spinous processes look like when your probe is in a longitudinal orientation, where you're going to see one spinous process superiorly and one spinous process inferiorly. and you're going to see, oh, this spinous process is about 0.5 centimeter to 1 centimeter from the skin surface. Then you're going to do is you're going to slide gently laterally. And sometimes the first appearance of some bony structure will look like a jagged appearance, and that's the lamina. And it means that you haven't gotten far enough. You want to go a little bit more laterally to that. So if you see, we're going to have here, we got the spinous process. We go a little bit more lateral. Those are the jagged flat lamina. So I'm going to keep going more lateral. And here are the round structures of your transverse process. And that is your landmark where you're going to put your needle. So here's another example of your spinous process right here. And as I travel laterally, I'm going to travel all the way until I see these sort of nice, smooth, rounded transverse processes. And all of this muscle, those are your erector spinae muscles. Sorry. So you want to image or get a good image of your transverse process on your screen. The technique is basically the same procedure as you were doing a fascial block for your femoral or your fascia iliaca. You will insert your spinal needle in plane and basically aim towards your transverse process. And you're going to advance until you see your needle tip run in contact with your transverse process. And if you see your needle going all the way, you'll in fact feel the resistance of your needle against your transverse process. And that's great. It says, boom, I'm there. I know I'm at the spot where I want to inject. You'll aspirate to make sure that there's no blood that comes back, but likely will not be because there are not that many blood vessels in the area. And then you'll inject. Again, this volume is your friend. You're going to inject about 30 cc's of analgesia. Again, a 20 cc of 0.25 bupivacaine, which is the same recipe as the fascia iliaca, and then 10 cc's of extra saline to get to that volume. And in the same way, you want to see separation of the erector spinae muscle from the posterior aspect of the transverse process. And again, you're going to see this opening up of a black bleb. And very commonly, when you stop injecting, you might see it actually collapse a little bit, which is an indication that you're actually in the fascial plane. So here's an example. It's a rather rapid video. Here is your transverse process. These are all your erector spinae muscles. And you're going to see a needle coming down from here, going all the way quite rapidly, right up against the inferior aspect of this transverse process. And as you go in, you see your needle tip going all the way until, boom, you hit the bone. And then you basically inject. And you're going to see this black area being spread, both posterior cephalad and caudad along the area. And when you stop injecting, there might be a little bit of a collapse of that black area or that black bleb. But you inject your 30 cc's in that area. And I kid you not, within 15 to 30 minutes, these patients will walk out of your emergency department. It is astounding how good these blocks can be. You have a question?
Actually, Annalie has a question. She's asking whether you could do it bilaterally and inject 15 cc per each, or you should reserve it to when it's unilateral. So
it's a very good question. If you're going to do a block because you're not sure, they may need bilateral, and the case reports talk about doing it bilaterally. I would then use, maybe 15 cc's and then add the volume of normal saline to get up to 30 cc's of total volume, and then 15 cc's on the other side. Remember, you can go up to a much larger volume of bupivacaine before you get to toxic ranges. So you can decrease the amount of bupivacaine on each side, but make sure the volume you inject is at least 30 cc's so you get that good spread across your fascial plane on both sides. But I have never needed to do it on both sides. These patients come in with very classic unilateral paralumbar muscle pain and muscle spasm. So I've never needed to do it both. I just do it on the one affected side. All right. So very, very quickly, and this is probably something that some of the guys who work in the trauma centers, as well as those who see elderly patients who come in with posterior rib fractures. I think this is something we should start doing much more commonly because, again, it's a safer technique and it decreases the amount of narcotics you're going to be using on these patients. So it's slightly different technique in terms of locating your transverse process in the thoracic area, which I'm going to show you right now. So in the same kind of idea, the premise is as you're injecting this large volume, that volume is going to start and spread to your the nerves that will be innervating your posterior and sometimes a little bit of your lateral ribs. And this way, this area, your anesthetic will actually spread 4 levels above and 4 levels below your site of injection. So it's actually a really good block in the thoracic area. And the technique is a little bit different. When we're doing in the lumbar area, I would tell you to start looking for by spinous process and then go lateral. You see your lamina and then you see your transverse process. What I would recommend is first start looking at your ribs and you're going to see lung sliding, and then slide medial until you see this new area of bone with shadowing, and you don't see lung sliding in that area. And there you'll know you're in your transverse process. So you're going to see ribs with lung sliding, and then slide a little bit more medial until you don't see lung sliding. And here's an example. So here's a rib right here. Here's a rib right here. Here's lung, but you'll know that there's lung sliding. And as I slide medially, I'm actually going to see bone, and then I'm going to keep sliding, and then you're going to see the jagged area of your lamina and say, oh, I've gone too close to the midline. Then I'm going to go a little bit more lateral. So here's lung sliding. I'm going to slide a little bit more medial. Here's the transverse process. Oh, keep going. Those are your lamina. I've gone too far medial, so I'm going to go back a little bit more lateral. That's my transverse process in the thoracic area, and I don't see lung sliding behind it, so I'm in a safe area. And again, the injection is exactly the same as we would be injecting in the lumbar area. Same thing as I did tell you before, make sure with every nerve block, you visualize your needle tip at all times. This is a in-plane approach, so you should be able to see the entire track of the needle. For back pain, this will likely not work for other causes of back pain, such as degenerative disc diseases, herniated discs, or patients who've had chronic pain for years and years. This is really meant for that severe acute onset of muscle spasm pain where these guys cannot even get off your stretcher, and you recognize that, you know, narcotics may be either dangerous or are just not going to work quickly enough. And I kid you not, the times that I've done this, these patients literally walk out of the room within 15 minutes and they leave the department. So as you know, Laurie has mentioned, and I hope I've proven to you guys, nerve blocks should really be a standard of care in our emerge. We use POCUS for a lot of cool things, such as, you know, lung and cardiac and that sort of thing. But nerve blocks is an extra procedure that we really, really should be using this on a more routine basis. And you should be getting those sort of nerve block kits ready to go so that you don't have to spend any time getting all the equipment ready. So again, ESP block, look for it, using it for rapid relief of your patients with acute low back pain. Consider it when you're seeing patients with posterior rib fractures, and will decrease your length of stay and possibly avoiding any short admissions for these patients. All right, any questions on this type of block? Let's stop sharing.
Yes, Dr. Bake is asking if there's any possibility to end up with an epidural/spinal shock.
Sorry, I didn't hear. Is there any possibility what up?
To end up with an epidural or a spinal shock?
Well, only if you've gone, I mean, only if you go into the epidural space. I mean, you're nowhere near the epidural space. You're injecting way lateral because you're past the spinous process, but past where you're going to be doing your lumbar puncture. So as long as you are clearly seeing your transverse process, and you can see the needle going all the way, and you stop at your transverse process, there's nothing there other than muscle and nerve that you're going to be injecting. And so I've never heard of any complications that end up with an epidural block.
Laurie?
There's what Joel mentioned is extremely important. You have to hit that bone. You really have to hit the transverse process before you inject. The person who described this, Ben Ho, that we Joel and I know very well, brilliant guy, said that there's this one report of someone really went into this space and then they created a spinal canal hematoma, but then went too far and then was not aligned, but also did not hit any bone. You know, at one point, that's the thing. If you don't follow your needle tip, you're not doing an ultrasound guided nerve block. You're really going blind. This is not something that you should be doing blind. So really make sure that you hit the bone to know that you're at the appropriate space to avoid this. But it's extremely rare. This is one case in all the procedures documented ever.
Okay, great. And I was wondering how long you keep them when you inject large volumes. I know you're under the toxic dose, but do you keep them 15 minutes? Do you?
Well, first of all, if you're going to have last, it'll start within minutes. So you're going to see right away the effects of last when you're using bupivacaine. Second of all, if you're using lower than the toxic dose, you are also less likely to cause any issues. Third of all, if you're doing it correctly with ultrasound guidance and you are withdrawing to make sure there's no blood, then again, you're doing a third safety feature. 15 minutes, these patients are ready to go home sometimes within 15, 30 minutes. So in that time, I observe them, I make sure they feel okay. But it's astounding that within 15 to 30 minutes, they literally, they come in a stretcher in extremis, and 30 minutes, they are walking home, and it's fantastic.
Great, thank you. I don't think there's any residual questions. Okay. Next up is our fellow, actually, Dr. Shuo Peng, who will talk to us about arthrocentesis.
Yes, okay. So let me just share my screen. By the way, I'm no longer a fellow.
Yeah, I was just going to say, Shuo is not a fellow. She's an attending staff at the Jewish.
I'm so sorry.
That's okay. All right, let's share.
You'll forever be young, Shuo.
Yeah, exactly. Yeah. All right. Okay, can I confirm if everyone sees my screen?
Yep.
Perfect. All right. So we'll go through ultrasound guided joint arthrocentesis. We'll go through it. We will switch gear a little bit. This is a pretty jam-packed presentation, so I'll try to go through as much joint as I can. I'll stop at the 25-minute mark for any questions, and if we don't finish every joint in the body, then that's okay. All right, so I have no actual potential conflict of interest. So the objective of this talk is to review briefly the evidence for POCUS guided arthrocentesis. We'll describe the general approach for POCUS guided joint aspiration, and specifically we'll look at shoulder, elbow, wrist, hip, and ankle joints. We won't go through the knee joint today because the knee is usually an easier joint to access even with the landmark technique. Although if anyone have question about knee joint, we can answer it later or in person if we ever have a scanning shift together. And last but not least, we'll describe common pitfalls of POCUS guided arthrocentesis. So without going too far back in terms of evidence, and there are tons of evidence that advocates for POCUS guided joint aspiration. The most, I think, impactful paper actually came out last year, and this was actually highlighted in EMRAP for those who are subscribed. And it's published last year in Academic Emergency Medicine. It's a single center prospective randomized clinical trial, randomized trial being extremely rare in POCUS. And they looked at patients with suspected median-sized joint effusion. The patients were randomizing to either landmark technique or ultrasound guided technique, and they recruited about 44 patients. So it's a relatively small study after all. But the finding is that the ultrasound guided technique was significantly better than landmark technique, with an overall success rate of 94% in ultrasound versus 60% in landmark, 60% being a little bit better than a coin flip. And of the 14 who failed the landmark technique, 8 really had no effusion later on ultrasound assessment. So that really speaks in volume of why we're doing this under ultrasound guidance. Another one that's also published last year looks specifically at point of care ultrasound for hip, for suspected hip septic arthritis. And this was a retrospective study that was published in the Journal of American College of Emergency Physicians. They looked at POCUS versus radiology ultrasound plus arthrocentesis, and they looked at specifically at time to diagnosis and time to arthrocentesis. There's in total of, I think 74 patients that were recruited, and the time to diagnosis was 1 hour in the POCUS group versus 3 hours in the radiology group. And more impressive is the time to arthrocentesis was on average 3 hours in the POCUS group versus 10 hours in the radiology group. So, you can see that it really shortens the time to diagnosis and time to arthrocentesis. They didn't really look specifically at some patient-centered outcome like mortality and morbidity, although we can imagine that shorter time to diagnosis will really impact both mortality and morbidity. Anyways, to anyone who's interested, it will be a really interesting question to look later on, specifically at those patient-centered outcome. So moving on, in general, what are we looking for when we're looking for joints? What does a joint look like under ultrasound? So the basic unit of a joint, first, the bone, you'll see the bone cortices who appears white or hyperechoic. The two ends of a joint form usually a V-shaped articulation, which you can see in most of the joints. Around the joint, typically you'll see this hypoechoic contouring, and that's really the cartilaginous surfaces of each of the bone that joins together. And within the joint space, normally you'll see a hyperechoic region, which is a fat pad. Now, when there's an effusion, instead of fat pad, you have anechoic fluid that displaces fat pad anteriorly. And we'll go over each joint and see what they look like. This is generally a sterile procedure. As you can see, septic joint is a disease that carries high mortality and morbidity. Obviously, we don't want to give patients septic joint by using procedures that are dirty. Chlorhexidine and sterile gel, sterile probe cover is something that I really recommend. Again, for surface analgesia, lidocaine or the local anesthetic works very well. You need a smaller gauge needle for the actual local anesthetic infiltration, but a bigger gauge needle for aspiration. And one of the pitfalls that we see often is that the needle that you use actually for aspiration is too small. And that can be a problem, especially if the joint fluid is a septic joint or hemarthrosis, where that small gauge needle just doesn't do the trick for aspiration. Depends on the joint, you might need a linear ultrasound transducer, or if you're looking at a deeper joint, you may need a curvilinear transducer. All right, so briefly going over each technique. So the technique that are most often used is the in-plane needle technique, which is described multiple times by Laurie and Joel. Essentially, you're going in the same direction as the ultrasound beam, and you visualize your whole needle. It is very elegant. It really allows real-time tracking of the needle. The downside is that you really need to have a good needle control and stability. So this is a difficult in terms of technique difficulty. This is a relatively difficult technique. And sterility can be kind of time consuming because you have to ensure both the sterility of your probe and of your needle. The other technique that you can consider is an out-of-plane technique. And for this one, you're going perpendicular to the direction of the beam of the ultrasound. And what you're looking for is really a hyperechoic dot as the tip of the needle enters the field of vision of the ultrasound. This can be pretty useful for deeper joints. Although, as you can imagine, if you're trying to calculate the angle of your needle, and how it can arrive at target, it can be kind of difficult. You do need to do a bit of mental math, and you might need multiple attempts to really get to the joint. And last but not least, you can do static marking for joint arthrocentesis, in where you locate the effusion, you mark on the skin where the effusion is, you take the ultrasound off, you clean your skin, you're kind of just going in perpendicular. The upside of this technique is that you only need to ensure the sterility of the skin and the needle, which is quite easy, and you don't have to ensure the sterility of the probe. It's a shorter trajectory, and it's great for small, medium joint, or if you have a very, very large effusion. All right, so starting at the hip. So this is a relatively challenging joint to tap. The method that I prefer is that you slide up to the joint. So first you start kind of mid-femoral. You want your probe in longitudinal orientation. You're kind of tracing your femur and proximally until you see the femoral head. You might need to rotate slightly to align with the joint, but that's the method that I prefer. The other one that you can also use, which is very useful just to identify the structure you want to avoid. You can kind of start with the probe aligned with the inguinal ligament, very similar to what you will do if you're doing a fascia iliaca block, and you locate the vessel proximally and the femoral head in the far field. Once you do that, you want to rotate your probe about 90 degrees to align with the joint. So what would the joint look like once you find the right place? You'll see the femoral head. Does everyone see my probe? Does everyone see my pointer? Yeah, perfect. Okay, so you'll see the femoral head, the neck of the femur, and you see a bit of the acetabulum. The area of interest is actually not where the acetabulum joins the femoral head. It's actually the anterior synovial recess that's just a little bit below the head of the femur. So around this area. So this is a clip that shows the fusion, as I pointed out before, in really the synovial recess. Over here, you see the acetabulum on the screen left over here, and you see the femoral head, but the fusion is actually a little bit below the femoral head. Again, this is a deeper joint. Assessment of fusion is a more difficult of the deeper joint than the more superficial joint. If there is any doubt, scan the other side to look for and confirm the presence of fusion. For a deeper joint, you definitely need a spinal needle. I again recommend an in-plane approach where the needle enters laterally in order to avoid the major vessel and nerve medially. The visualization is very similar to if you're doing a femoral nerve block or a fascia iliaca block. Obviously, you're going much deeper, and you can use either lidocaine for both analgesia and hydrodissection to locate your needle. You can aspirate or starting to aspirate once you hit bone. All right, moving on to next joint, which is a little bit smaller. We're skipping the knee again, is the ankle joint. This one is one that I use most often in the ED. So you want the patient to be sitting or lying down with the knee flexed and ankle in slight plantar flexion to open the joint. Again, the approach to finding the joint is walking up to the joint. So first you place your ultrasound longitudinal orientation mid-tibia, and then you kind of slide down the tibia medially to get to the joint. What does the joint look like? Once you get to the joint, you'll see the distal tibia and the talus forming a nice V. The joint space is that V. So on ultrasound, it looks like this. You have the tibia on one side, you have the talus on the other side. You can note that here we really see that cartilaginous surface very well on the talus. And the joint space you're looking at right here is filled with fat pad, which is this, isoechoic or slightly hyperechoic area. What an effusion will look like is an anechoic area that displays the fat pad anteriorly, and that will look very similar to what you see over here. So how do you approach aspirating this joint? I recommend the anterior medial approach, which is exactly how you find the joint in the first place. You slide down the tibia medially. Ideally, you want to be between the tibialis anterior and the medial malleoli, or you can even go between the extensor hallucis longus and tibial anterior. If you're wondering how to locate these two tendons, just have the patient dorsiflex, and these are the two tendons that pops up really. You want to really avoid going more laterally because that's where the artery and the nerve are located. Of course, if there is a localized effusion laterally, and that's really where you want to access, you can absolutely go there. Just make sure that you use the Doppler function to first identify the artery and second to avoid the artery. All right, so upper extremity, we'll go for shoulder. So the approach to shoulder to locate the shoulder joint is very, very similar. Actually, it is exactly the same as if you're doing a reduction or a scan to see for shoulder dislocation. You want to go just beneath the scapular spine, slide laterally until you arrive at the joint. And the picture that you should be able to generate, or the picture that you aim to generate, would include a bit of scapula, glenoid, and a humeral head. The joint, the space that we're interested in is the glenohumeral joint. All right, so what does a fusion look like? We know what a dislocation looks like. The fusion, you're really looking for, again, the displacement or absence of fat pad that exists normally. So again, on the picture on the picture on the left side, you see the glenoid, the humeral head, and between them, a nice isoechoic, slightly hyperechoic fat pad. When there's an effusion, that becomes completely anechoic and displaced. This is another more subtle example of an effusion using a linear probe. On the left side of the screen, you see glenoid, humeral head, and in between a nice fat pad. There is a pretty prominent cartilaginous surface that we can see on the humeral head, and you can easily imagine how you can kind of confuse that with an effusion. Now, on the contralateral side, which is the abnormal side, you have the glenoid, the humeral head, and all these anechoic fluid that kind of displace the fat pad anteriorly. This one is quite subtle. If I see something like this on ultrasound, I definitely want to get the contralateral side just to confirm, because you don't want to be poking into a deep joint when there's actually no effusion. All right, so how would you aspirate the joints? It's essentially you want the patient to be in the same position as if you're doing a shoulder reduction, either sitting or lateral decubitus with the affected shoulder up. Contrary to the other procedure or the other joints, you, instead of trying to opening the joint by internal rotation, you want to externally rotate a little bit to kind of pull the effusion. Again, you know, if your patient's really limiting movement, it doesn't really doesn't matter. Again, it's a deeper joint, so you want to try to use a deeper, you know, a longer needle, and the one that we have access easily in the emerge is a spinal needle. The picture here shows autoplane technique, where you kind of center on your area of interest using the MO marker kind of to help you. The other one that I think works better in my personal experience is, again, the in-plane technique, where you kind of just, you know, go from medially to laterally to access the joint. And that one you can really visualize your needle going all the way through. All right, so let's talk about the elbow. So again, in terms of position, you want to really open up the joints. Ideally, you want the patient to have the elbow in 90 degrees, and this they can do either lying down with a pillow underneath, or they can be sitting and holding their affected hand with their contralateral hand. The flexion of the elbow opens up the joint and displays the olecranon to be outside to essentially to avoid the olecranon process. Again, to find the joint, you're walking down the joint, starting with ultrasound longitudinal orientation in the mid-distal humerus and kind of sliding down until you get to the joint. What would you see once you get to the joint? So you'll see the distal humerus and the olecranon fossa. Overlying, you see the tricep and the fat pad over, you know, normally you see a fat pad overlying the olecranon fossa. You definitely want to image this joint in 2 dimensions because you'll be aspirating in the transverse orientation. In the transverse orientation, you see the olecranon fossa that dips down nicely. Again, the tricep tendon and muscle overlying, and the fat pad that normally exists in the joint when there's no effusion. What does an effusion look like? On the left of the screen, you see the normal anatomy of the joint with the distal humerus, olecranon fossa, and the fat pad. And on the right, instead of fat pads, you see an anechoic collection corresponding to joint effusion. Same thing in the transverse orientation. You see the dip of the olecranon fossa and the fat pad that exists normally, where when there's an effusion, you see anechoic fluid. So this is joint aspiration you really want to approach with the probe in transverse orientation. You want to make sure that you approach the needle laterally, so from the radial side, to first avoid the tricep tendon posteriorly and the ulnar nerve medially. You want to use the in-plane technique as shown here. And you can see the needle coming into the effusion. All right, last but not least, the wrist. This is also something that I find myself doing quite often in emergency. First, we see a lot of patients with wrist cellulitis or cellulitis affecting the wrist area, and whether there's an effusion underneath that cellulitis is something that we want to figure out. So positioning wise, you want to have the wrist again in slight flexion to open the joint. This is a common thread in how to approach a joint POCUS. You want to start with ultrasound again longitudinal on the radius at the level of mid forearm. And again, you're sliding down to get to the joint. And the target that we're looking at is the radial scaphoid joint, or the joint between the radius and the scaphoid. So what does that look like? Once you get to the distal radius, you see the radius dip down and the scaphoid and the scaphoid bone that comes up more distally. Again, you see that nice V indicating that this is a joint, and the fat pad that would exist normally between the joints. When there's an effusion, you'll see hypoechoic or anechoic fluid that displaces the fat pad. All right, so where would you want to do your aspiration? Again, because you're trying to find the joint, the approach to finding the joint is to find it more on the radial side. You want to approach it at the same level as you find the joint, which is between the extensor pollicis longus and then the extensor digitorum tendon. You want to be slightly distal to the Lister tubercle, just because that is the point where you have this little bump. And again, you want your wrist in slight flexion and ulnar deviation in order to open up the joint. All right, so that's all the joint that we're going to cover. We're going to talk briefly about common pitfalls. So first, is there truly an effusion? How do you make sure there's an effusion? You want to get as much as possible two views. And if you're unsure, or if it's unclear and it's a deep joint, you can always compare to the contralateral joint to have a better idea. The other common pitfall is that you can access a vascular structure instead of the actual effusion. And the point of avoiding this, or the way to avoid this, is to use color Doppler. Again, when we're talking about vascular structure, we're mostly talking about arteries instead of veins. And definitely the Doppler can help you avoid those. Last but not least, actually the most important, is needle visualization, which is always a struggle, whether you're doing nerve block or aspiration of a deeper joint. First, make sure your needle is long enough. I cannot tell you how frustrating it is to have a short needle. You get to the joint and you're so close, but it's just not long enough. The second up, one thing that you can do to really help with needle visualization is bevel up. You can imagine that the way that we see needle is by a bounce back of the light that reflects off the needle. So the bevel up, the bevel of the needle itself actually creates a different echogenicity than the needle itself. If you remember, or you can think about how a needle looks, the outside of the needle is nice and smooth, but the bevel area is a little bit marked. So by just having the bevel up, or the bevel pointing towards the ultrasound, the direction of your ultrasound, it can really make a difference in terms of how it appears on the ultrasound, on your ultrasound. Slow and steady is the key. Sometimes I see residents going faster and they don't see the needle. They just want to get to the joint. That actually doesn't help. The whole point of ultrasound is that you can see the needle and slowly approach the target without having to attempt it multiple times. A common trick to really see the needle is that you want to start with your needle at a reduced angle of insertion, because the more parallel the needle is to your ultrasound, the better you can see. So if you start with the needle with a reduced angle, and then later on increase your angle once you see your needle very well, that can really help you to localize your needle. And again, using lidocaine or sterosaline for hydrodissection if you're looking at deeper joints. So we have lots of time for question at the end of my presentation.
Thank you so much. I don't see any question yet in the chart. I guess I could start with one. You've shown a clear effusion on a shoulder image. Could that be confused with dislocation? I'm sorry, I should have asked it when you had the image up.
So yeah, you can. So whether there's a dislocation, so first of all, whether there's a dislocation and a fusion that can exist in the same time, absolutely. You can have dislocation that in itself produces an effusion, whether it's because of injuries, whether there is a fracture with a dislocation. So that can absolutely happen, but you're not really tapping a joint when it's dislocated, right? You know why there is an effusion, because there's a dislocation. Specifically, I think what we're looking for is whether, without any dislocation, why is there an effusion, and whether the effusion really is a septic effusion. So you mean, and maybe you're talking about this picture?
Yes, exactly. Yeah.
Okay. So there's no dislocation here, and it might be a little bit difficult to see, but normally when we're looking for dislocation, which is another lecture on its own, you're really looking at this nice curve in the subscapularis muscle, instead of an angle when there's a dislocation. There you can't really see, because this is a linear probe focusing at the joint itself, not really looking at the muscle. The same thing with dislocation and effusion. You just want to check the contralateral side to see differences. But if the question is, can there be an effusion with a dislocation? Absolutely yes, but you're not tapping those joints. We're specifically looking for effusion in joints that are not dislocated, that are not acutely traumatic, and where you're suspecting more of a septic joint than anything else. Yeah.
Laurie?
My love for shoulder. So I really love shoulder. And one of the things that's going to help you this, because let's say you put your probe, the patient has a super swollen shoulder and you have no clue what's going on. They have a lot of pain. And then what you see on the screen, it looks like it's dislocated, but it's actually subluxed. It's pushed down by the effusion. There's so much space in that joint that basically it's going to push down your ural head. One of the things you can do, and I always tell you whenever you locate back a shoulder, grab the elbow and do some internal and external rotation. Okay, they might have pain, but you will be able to do the movement. If they're dislocated, you won't have any movement of that ural head into that glenoid cup. Even though there's an effusion, you should be having some movement. But if you're dislocated, you won't. That's one of the tricks. I would say clinically, just try to range them. But yeah, it will create this appearance definitely of a subluxation of the especially when it's a big effusion. It's a great question.
Great. Are there any other questions? Lots of things were covered in this: hip, ankle, shoulder, and elbow and wrist.
Yeah, it's definitely a really full lecture. Practice is everything, and without practice you can easily forget everything. So a later date will probably if we have the chance to practice it either in a specialized day or in clinical setting, you can definitely keep the presentation for later reference, because we really did go over a lot of joints.
And people will be able to use this presentation that will be available as a tool of reference. So that's great. Since I don't see any question, I think we could go for a small break. We had 15 minutes, Jake, planned? Yes, 15 minutes. So 10:45. Okay, so what about we come back at 11? Would that be okay? Maybe 10:55. Laurie, do you still have your hand up? Take it as a no. Okay, so
My
10.
what?
Do you still have your hand up?
Oh no, it's down.
Okay. Okay, so 10:55 we'll start back.
Alrighty. So we're at 10:55. We have Greg up next, I believe. Great.
Hey guys.
I can see your screen.
Excellent. Perfect. All right. I hope everyone's having a great day so far. As is usual for my ultrasound presentations, I got back from Valleyfield at like 4 a.m. last night. So hopefully we'll be putting coherent sentences together again. So today we're going to speak about ultrasound as it relates to the lumbar puncture. All of you either own this book, will own this book, or have borrowed it from a friend. So The Essentials of Point of Care Ultrasound by Steve Socranci and Ray Wiss. Joel also, I believe, has a couple of chapters. I don't remember I and another one. But there is actually a chapter on lumbar puncture. There's a chapter on procedural skills, and it's a really, really great resource. And I've stolen a few images directly from their book. So if you want to a secondary resource for today, you can go ahead and read that chapter. It's only a few pages long, and it's really, really good. Just a disclaimer. So today we're going to talk about ultrasound as it relates to the procedure, but I'm not going to be discussing necessarily the details of the procedure itself, sterile technique and needle size and needle guidance and those sorts of things. We're really going to talk about the ultrasound, how that can contribute to the procedure. And we'll be talking about the static technique specifically. All right. So case number 1, we'll start with a quick case. You got a 19-year-old. She's got fever, headache, and stiff neck. No medical history, no meds. Temperature of 40, heart rate of 130, borderline blood pressure, looks terrible, has a stiff neck, photophobic, and vomiting. Jake, you appropriately, doing your appropriate diligence, think of meningitis as a diagnosis. You turn her around to do the lumbar puncture, and boom, right? See the vertebrae all the way down the back. Obviously, this is thoracic at this level, but this will not be a difficult lumbar puncture, and you're able to successfully tap the joint and diagnose meningococcal meningitis. Good job, life saved. Case number 2, what I think will highlight the utility of ultrasound for lumbar puncture is her 52-year-old father. So he refused the antibiotic prophylaxis after having a prolonged exposure to a patient with a meningococcal meningitis. He comes in 2 days later with the exact same symptoms. And unfortunately, when he takes off his shirt, he looks something like this. And you can imagine how the lumbar puncture at this point would be much, much, much more difficult. This is actually a picture, if you go on Wikipedia, obesity, the grading, this is the first picture that comes out. So I'm not picking on anyone in particular. This is apparently a gentleman who weighs 400 pounds. And you can imagine how finding the anatomic landmarks using the classic technique of palpating the iliac crest or the posterior superior iliac spine, trying to bring it to the midline, palpating your spinous processes, those will all be very, very difficult, if not impossible, to try and do anatomically. And this is where ultrasound really, really, really shines. What evidence? So don't sort of believe anything anyone says without a little bit of evidence to back it up. There's actually a recent systematic review and meta-analysis in 2019 where that included 12 RCTs with a total of nearly 1,000 patients, so a decent amount of patients, that compared the landmark approach versus ultrasound assisted. And use of the ultrasound for lumbar puncture actually resulted in a higher success rate, fewer attempts, fewer traumatic taps, and a shorter time to successful lumbar puncture. I think that's really great thing to keep in mind because a lot of the time with ultrasound, you'll get pushback from people who don't use it often, that it takes too much time. Well, in the right hands, when you've practiced it a few times, you actually will be quicker at doing your lumbar puncture because you will not have those, you'll have fewer of those failed attempts, and you'll be able to feel and diagnose your anatomy immediately. It will not be difficult. So keep that in mind, even for those patients that have very, very easy anatomy. All right, so how do you do it? It's 4 steps that I sort of describe when I'm teaching this. So first, you're going to position and prepare the patient, and this is really, really key. Second, you're going to identify your spinous process in the transverse plane. Third, you're going to identify the interspinous space in the longitudinal plane, and you're going to mark your skin, and you're going to go. I only teach the static technique. For reference, there actually is a sort of dynamic real-time guidance technique that's mostly used in the anesthesia literature that you can actually see your needle travel through. But it involves a different approach and not something that I think is easily translatable, excuse me, to someone who's already comfortable doing the lumbar puncture using the standard landmark-based approach. So the static technique helps you find your target, and then you go on with your normal lumbar puncture as you otherwise would. It can also help you determine the depth of the needle that we'll speak about at the end. So in terms of the first step, so position and prep is really, really important. You can do this both sitting and lying. I have a preference for sitting just because I find it's easier to maintain the spine in a straight line, but obviously not everyone is going to be able to sit for this procedure. It's very, very important that the patient is comfortable, because once you start doing your landmarking and you find your spot, if the patient has to reposition themselves because they're uncomfortable, then you have to restart, because you may not, your skin markings might have shifted slightly and you may not be actually in the spot that you think you are. So it's really important that you position the patient comfortably, you position yourself comfortably, so that, for the 5-10 minutes that you're doing this, nobody needs to move. You can use the linear probe in some patients who are thin enough, but for many patients, you might end up having to use the curvilinear probe if there's some amount of adipose tissue that's there. So how you start is you're going to start to identify the spinous process in the transverse plane. So you're going to put your probe marker over the lumbar spine, and we'll speak about at the end about if you really can't even find your lumbar spine, how to start. But assuming you can palpate the iliac crest, you can just slide over and place your probe at about that level. You are going to have your probe marker pointing towards the patient's left. Ideally, the screen would actually be in front of you here, as opposed to off the screen, the way I have it laid out. And you're looking for a midline hyperechoic structure that's got some good shadowing. When I started doing lumbar puncture, I was always really annoyed because I found that the images showed a really, really clear hyperechoic line and a very dense shadow, and oftentimes it's a lot more subtle, and I'll show a few images of that after. So if you remember our lumbar spine anatomy, so you have your spinous process, that's a single midline structure. Paired off of that are your paired lamina. Then you'll have your superior and inferior facets, and then your transverse process with your vertebral foramen in the middle. On ultrasound, you will see sort of all of these structures. So you'll see your spinous process with, in theory, a hyperechoic line with posterior shadowing. You have your paired facets and lamina, and you'll have your paired transverse processes. Depending on where you are in the interface or the interspace, you may actually see through to the vertebral body and the ligamentum flavum as well. And we'll speak about that a little bit later. What this looks like according to the book, right? A nice bright hyperechoic line, some nice dense shadowing. You've got your paired lamina on each side. Okay, this is posterior because you're scanning from the back. This is anterior. What I find more in real life, what I'm seeing is something that maybe looks like this. And my colleagues who've done a lot of this as well can agree or disagree, but I find oftentimes I'm sort of missing that really dense hyperechoic line that I see in other bones. And I'm often basing this based on the shadow. And the way you're able to diagnose this just based on the shadowing when there isn't that evident hyperechoic line is that it's the only single midline structure. So all of the other vertebrae that come off are actually, all the other vertebral structures that come off at this level are paired, right? So you've got your paired lamina on each side, you have your paired transverse process on each side, but your single midline structure that comes most proximal to the skin is your spinous process. This is another example here, right? Even more subtle. Again, how this always annoyed me when I was first learning it. You don't have that much of a hyperechoic line, or really at all here, but you do have the nice midline shadowing with your paired structures and shadowing on each side. What you also notice is if you look off to screen right and screen left, you actually do have the paraspinal muscles that you'll see sort of insert into the spinous process that can help guide your eye a little bit to make sure you're heading towards the right structure. So once you've actually identified the spinous process, you want to center it on your screen. And then once you've centered it on your screen, you'll see that you have little hash marks at the center of your probe, and you want to mark the skin at that level. So typically I'll make a mark here, I'll make a mark at the other end of the probe, and I'll connect them, and that will be my first line of midline. And midline is honestly half the battle. Like if you have trouble finding the interspace, but you're able to reliably identify midline, you might poke the patient a bunch, but you'll get a successful tap. Because when you this is sounding a little bit crass, but when you're failing lumbar puncture, it's usually not as a result of needle angulation in people that have a decent amount of experience. Is usually just because you're just off on your landmarks. You're either and typically that's going to be you're too far right, you're too far left. Very rarely, if you're able to sit a patient up, keep them straight, identify midline, will you be unsuccessful in someone that doesn't have other reasons to have failed attempts like lumbar surgery and etc. So this is really, really the main crux of the technique. Make sure you can identify midline. Next, you want to switch into the interspinous space. Excuse me, you want to identify the interspinous space. So you're going to switch into the longitudinal. Here they're using the curvilinear probe. The probe marker is going to be cephalad, and what you're going to see is you're actually going to line up your spinous processes on the screen. And again, you're looking for, in theory, this midline hyperechoic structure with shadowing far field to it. In the book, again, this is what you see. So you see a nice hyperechoic line with some shadow, hyperechoic line with some shadow, this being your interspace. What I find sometimes a little bit more realistically is a bit of more of a faint line with some shadowing that's coming off, and these stars are representing your interspace. And much like we did before, you're going to want to take your probe, center it, so center the interspace on your screen, and then mark the skin at that level. And congratulations, at this point, you can move on to the next step, which is actually marking the site, okay? So if you've marked your interspace, you've marked your midline, you've made a target, and you know exactly where you're going to go. I do want to point out that it is important to be wary of when you're trying to find your interspinous space, that you're actually on the spinous process. So if you notice here, the spinous process is not a very wide structure, right? So if you imagine when you turn into your longitudinal axis, all you would have to do is slide your probe sort of a couple of millimeters in either direction, really, really not very far, and you would fall off your spinous process and onto the lamina. In order to make sure you don't make that mistake, what I'll do is when I'm in the transverse process, I'll note approximately how deep this is, right? Because there's a good amount of difference between the depth of the lamina and depth of the spinous process. So if I know this is 3 centimeters to the skin, when I'm in my longitudinal axis and what I think is the spinous process is 5 centimeters or 6 centimeters deep, I know I'm looking at the wrong structure, and I'm going to just slide slightly back and forth to try and find the spinous process. So once you've marked your site, like I said, you can sort of go forward with your technique. I have gone away from using markers. I find using a permanent marker on a patient's back that they can't actively like clean realistically is sort of mean. What I'll typically do, because I'm a little bit more comfortable, is I'll use my needle caps and I'll just make marks in the skin with indenting. So I'll press my needle cap into them until it indents. And if you move with reasonable amounts of speed, you'll be able to put a nice midline center target and finish your procedure, and the marks will still be there. When you're just starting with this technique, or if you're a little bit more uncomfortable, certainly the permanent marker is a fair way to go. I've just sort of moved a little bit away from it just to be a little bit friendlier to patients. So again, if we have to sort of review our techniques, you're positioning and preparing the patient, again, emphasizing that the patient has to be comfortable to be able to sit there for 5 minutes, because once you've marked the skin, if they move, you're restarting. You're starting in your transverse plane to identify the spinous process, which we identify primarily based on the shadow. Sometimes you get the nice hyperechoic line, but not always. Then you'll switch into a longitudinal plane to identify the interspinous space, and then you're marking your site. And that's the crux of this technique. It's not exceptionally difficult, and it does improve outcomes for your patients. So I highly encourage you to use it. So what happens in those patients that you essentially have no landmarks? You especially in patients that have a morbid obesity type body habitus, and you go to feel the iliac crest or the spines, the posterior spine, and you can't feel anything. And I think we've all sort of been there when you're feeling and there's no bony landmarks whatsoever. Those patients, you can still use ultrasound. In fact, these are the patients that are the best to use ultrasound on. But when you can't determine your level at all, there's sort of 2 things that you can do. One is you can actually use the probe to identify the iliac crest and sort of half use use it as a sort of surrogate for your landmark of the iliac crest. But even that can be a little bit more challenging depending on how much adipose tissue there really is. But everybody's got a butt and two butt cheeks, and between that is a cleft, right, for everyone. And so if you put your probe in that cleft, what you're going to actually find is you're going to see the sacrum. And the sacrum is different from the lumbar spine in that it's a broad sort of shelf almost of a structure. And it's got a hyperechoic line that's definitely hyperechoic because it's a broad bone. It's not so much like the spinous processes. And you can actually follow it superiorly. And then what you'll see as you follow it superiorly is you'll find the spinous processes of L5, L4, and L3 that follow as you slide superiorly. So if you fail all your anatomic landmarks to even know where to start, go as far down as you can in between the glutes and basically identify the sacrum and start from there. The other utility of ultrasound, which is a lot of fun and has certainly saved me some headaches, is to know how deep to go. There's a few different ways to do this. The way that's often the easiest is sort of the alternative route that's recommended in most of the literature. So what you're going to, which is identifying the spinous process. I'll complete my sentence there. So what you're going to want to do is you're going to want to go back into the transverse plane. You're going to want to identify your spinous process as you did previously and slide just a couple of millimeters more cephalad. And as you'll do that, your spinous process shadow will sort of start to become less prominent and fade away. And far field to that spinous process, you're going to see a sort of a faint white line that represents the ligamentum flavum. And in the textbook, what they say is it's supposed to look like a smiley face. So your facets / lamina into your ligamentum flavum, back up to your facets, supposed to look like a smiley face. I never found it all that smiley facey, but that's the theory. What you also note, though, is that the level of this ligamentum flavum, if you're all buying what I'm selling, that this is in fact the ligamentum flavum, is about the level of your transverse process. So if ever you're really unsure, you can cheat by just measuring the distance to the transverse process. And so what you do is you can measure, you can hit freeze and measure this distance here to know what size of needle you might need. And most importantly, is the size of needle that you have long enough? Because there's nothing worse than sort of hubbing out your needle and realizing that it's just not long enough, and you're having to go call a nurse to get something longer, go up to the OR sometimes to get a needle. Keep in mind that if this is, let's say, 5 centimeters, that functionally you may end up, because you're angling your needle a little bit, typically you might end up needing a longer needle than 5 centimeters, just using, the Pythagorean theorem. So keep that in mind, that you're not surprised if you go a little bit longer than what you've measured. So for me, I'll often look over at the transverse process and I'll use that as my ballpark because I find that ligamentum flavum is not always the most readily apparent. So it's a nice quick talk. I think I'm probably under time, but for lumbar puncture, I encourage you to use it on all of your patients when you're starting. Not only, like we discussed, does it improve your chance of success, it decreases your attempts, it decreases your risk of traumatic taps. You have fewer attempts. And so that's all a benefit to your patients. And the more you practice on patients that are easier, the more confidence you will have in the patients that are much, much more challenging. And there's nothing more satisfying than if you're the one that's able to get a very difficult poke, like in putting in a peripheral IV when no one else can get it, doing a lumbar puncture when no one else can get it too is very, very satisfying. So I encourage all of you to try. If we're on shift together and we have a lumbar puncture, will you be using ultrasound? And I'll make sure if any of you guys are in the department, I'll come and grab you. Any questions? Joel, oh no. How can I help you, Joel?
No,
if
it's not a question.
Contributed to this chapter, I'm gonna be red in the face because I didn't know this.
Yeah, great talk. Thanks for doing this post difficult shift in Valleyfield. I just want to make one. I want to repeat one important concept that Greg mentioned. The goal of your transverse view to look for your spinous process is twofold. One is to find your midline, because if you can't find your midline, you're not going anywhere. And second of all, as Greg mentioned, is to identify your depth of that spinous process, because as soon as you move to the longitudinal view, as Greg mentioned, since moving 5 millimeters to the left and 5 millimeters to the right, you're off the spinous process. And all of a sudden you see this white echogenic structure, bony structure that you think is the spinous process when it's in fact a lamina. It's really important that you recognize when you're in transverse, that spinous process is 1 centimeter from the skin surface. Therefore, when you move to longitudinal, if you see something that is 3 or 4, that ain't the spinous process. Go back and look for that same structure that was 1 to 2 centimeters off the skin surface. So I just want to reiterate, because that is something that I have seen very, very commonly, that you sort of slide off. So what Greg said, it's really, really important. And second of all, I would strongly recommend that you do not practice on your first obese patient that needs a lumbar puncture, because you'll become very frustrated. You won't see the anatomy, you won't see the structures. You'll sort of start swearing at Greg, saying, well, it looked way easier when he presented it. Do it on your very next lumbar puncture. Even though you say to yourself, I don't need it, it is always good to practice the image generation so that you are comfortable with normal anatomy, so that when you get the difficult anatomy, you are already comfortable with it. So really don't just wait for that difficult lumbar puncture. Do it on everybody. And then finally, as Greg mentioned, there is nothing more satisfying than getting a procedure done when nobody else can do it, especially the neurology staff who were like, wow, you got a lumbar puncture and we couldn't. So and they want to learn how to do ultrasound guided lumbar punctures, which is great.
Thanks, Joel. Yeah, I completely agree. I think when I started my first attempt was on an extremely difficult lumbar puncture, and I 100% failed. So when you practice and you're comfortable looking for those shadows, because they're a little bit more subtle than you expect for bones, when you're confident seeing those, it'll really make your life a lot easier on the more difficult cases. I saw Jerry's hand up, but went back down. All right.
Any other questions by anyone before we move on?
I actually have one. Greg, I had exactly that case the first time where I used the ultrasound to do my LP. The patient was fat, had a strong body habitus. I'm sorry.
Yeah, no, it's okay. Let's see. The patient was obese. We can use the medical term. Fair enough.
Had a previous discectomy just in L4 and 5, and then had a very tortuous spine with a lot of scoliosis. Are there specific tips for these when the spine is really like tortuous? Because when the case ended up with anesthesia coming in, and where I had identified my landmark, he went like 2 centimeters, like at least 1.5 centimeters on the side. Could that have been picked up with ultrasound? I know it's kind of hard because you didn't see the images.
So it's hard to know exactly. So because I wasn't there. But what I'll say is sort of a couple things. One is what's sort of cool about ultrasound is if you know there's a disastered L4, L5, well, you can just go an interspace up, right? Because you can start the sacrum and you can identify and you could pick out the easier interspace. So no use trying to fish something through a fused spine, and that just makes your life impossible. The other thing with the anesthetists is they have there's evidence about a paramedian approach, and so they might have been using real-time guidance or just their own general landmark approach with a paramedian angle, and that's not something, I'll be honest, that I've ever done or am necessarily comfortable doing, but it's something that the anesthetists do use and are trained for. So it's possible when they went 2 centimeters off, it's because they weren't using a midline approach, they were using their paramedian approach and coming in at an angle, and that might have made things easier for that particular patient. So to answer your question, it can still help, because if you know there's a disastered L4, L5, you're not going to be able to flush it in. We know that with the classic anatomic approach that if you just you palpate the crest and come in, that's L4, that for the majority of the patients that's not actually the case. So you're usually an interspace higher and interspace lower. So the ultrasound will allow you to know what interspace you're at, select a good interspace. Although it may not be, if someone's got a whole spine that's fused and severe scoliosis and a whole bunch of other issues, it's not 100% bulletproof, but it gives you your best attempt, your best realistic attempt. Hey, Paul.
Yeah, and Sophie, just to add to that, if you're concerned about a very crooked back, I would also recommend that you go one spinous process, when you're doing a transverse view to look where your spinous process is, go one spinous process above so that you can see if it's sort of moved over to the left and move over to the right. Therefore, you have a sort of an idea of where the midline is moving, whether it's a little bit left, a little bit right. So do two spinous processes so that you can know in which kind of plane you're looking for.
I would add to that, like I had great success with like very bad scoliosis. Make sure you align your spinous processes properly with the linear probe when you're longitudinal. It will tell you a bit how the spine is moving. And like Greg said, I suspect that the anesthetist probably use a paraspinal approach, a paramedian approach, which they use quite often actually in anesthesia. So it's possible that you were not wrong at all. It's just that it's a different technique altogether that he used.
Great, thank you. But I'll definitely take the tip of practicing on easier patient first, Yeah. That was
the way to go, and I've been there with the frustration. And Sophie, don't worry. I did the exact same thing on my first attempt, so I understand.
Okay. Anyone else? Or thanks so much, Greg, and I really appreciate you coming post night shift or late shift. All right, Paul, all set for you.
All right, let me just share my screen. Can everyone see my screen pretty well?
Yeah, we got it. Yeah, looks great.
Excellent. So today I'm going to talk to you guys about ultrasound-guided pericardiocentesis. And a pericardiocentesis technically is a halo event, right? A very high acuity, very low occurrence event. So it's difficult to have experience with it necessarily in the emergency room technically. One thing that could be done to get more experience with that would be to speak with your local or hospital-based cardiologists or cardiac surgeons who does do these pericardiocentesis on patients who are not as acute, and maybe assist to one of them or go and offer, sometimes to let you essentially that's assistant pericardiocentesis, or even do it under supervision with them to get more familiar with the technique. 1 second, this should be okay. So I have no conflict of interest to declare. The objective is really to review the indication of pericardiocentesis, but you can't really talk about pericardiocentesis without talking about the basics of cardiac tamponade as well. So we're going to do a quick review of tamponade and some clues on ultrasound of there could be tamponade. We're going to also go over different techniques for pericardiocentesis, and there's one technique specifically that I want to put forward for, especially if you're going to attempt this on your first attempt and never done this before, which seems to be, to me, the safest approach to be able to perform that procedure. So the indication truly is cardiac shock from tamponade, okay? And that's truly a clinical diagnosis. That's essentially when your intrapericardial pressures equate to your intracardial cardiac pressures, and then you'll have collapse of your filling pressures of your heart, and then that will lead to shock hypotension. That is the main indication. So it's shock, okay? So somebody who's hypotensive with a pericardial effusion, that is your indication to go and grab some fluid and do your pericardiocentesis. Now, there's been a different scoring index that has been proposed to determine whether or not this has to be done emergently versus delayed a bit. And they usually use a scoring system that looks at the etiology of your effusion, the obvious clinical presentation, and also the echocardiographic findings to determine that. There's also something very important to understand is that on ultrasound, you can have what looks like tamponade physiology without having necessarily the clinical signs and symptoms. And that's called subclinical tamponade. And that is not an indication to do your emergent pericardiocentesis. So if the patient has a normal blood pressure and is not, it may be a bit symptomatic from the pericardial effusion, but is not in shock, even if you have some tamponade physiology in your ultrasound, don't necessarily get out your pericardiocentesis kit right away. And that mainly is because, you can have different presentations. The two main determining factor whether your patient's gonna present a tamponade or not are gonna be mainly the etiology of your pericardial effusion, but also the rate of accumulation of that pericardial effusion. So imagine that you have a patient who's hypovolemic. In that patient who's hypovolemic, a small pericardial effusion could cause tamponade physiology, technically. Or the opposite is also true. If somebody has lots of elevated right-sided pressures, they can probably withstand a lot more intracardial pressure before you see essentially the tamponade physiology, before you see the RV collapse and right atrial collapse, just because of those increased right-sided pressures. So the pre-existing conditions of your patients will also change the presentation of your patients, even if you see a large effusion or small effusion. So if we talk quickly about pericardial effusion etiologies, you can go about it with a differential diagnosis based on your symptoms and presentation. One thing that can also be useful is the size of the pericardial effusion. Usually a large pericardial effusion will be more associated with malignancy, TB, hypothyroidism, and a small effusion usually is more idiopathic or viral. And then also the rate of accumulation, which sometimes is hard to know, but if the symptoms happen quite suddenly, you have to think about aortic dissection, cardiac rupture, especially post-MI. And the reason why I put this slide is because your approach to pericardiocentesis might be a bit different if you're suspecting an acute aortic dissection, a hemopericardium or cardiac rupture, like essentially a free wall rupture. You have to be a bit more careful as you do the procedure. This is a nice curve that essentially shows you that a slow effusion, essentially you can accumulate a lot of volume before you're starting to see increased pressure in your intrapericardial space. In the rapid effusion, you'll see essentially a rapid increase of pressure. So small effusion does not necessarily mean no tamponade. Obviously, a moderate effusion to a large effusion can definitely increase your suspicion quite a bit of cardiac tamponade. The other thing that's interesting is if you look at the delta, so if there was a rapid effusion, essentially a very small decrease, a few cc's that you remove from that pericardial space will also cause a big drop in that pressure. Okay, so that's something also to consider, especially in the context of free wall rupture, post-MI, or aortic dissection. When we talk about tamponade, obviously everybody thinks about pulsus paradoxus. What is it? What happens? And it goes to show a bit what we'll see on the ultrasound as well when we're talking about tamponade physiology. So if you suspect that somebody's in tamponade, obviously you want to see this clear pericardial effusion, but one of the things you can look at is your right ventricle. And if you look at these curves, okay, here you have expiration, inspiration, and what you'll notice essentially is that with inspiration, you'll have bulging of your right ventricle, so there's increased filling pressures from the venous return, and because the chambers are not equal in pressures, with inspiration, there's going to be a septum deviation into your left ventricle. And the same thing will happen. As soon as you essentially breathe out, you're going to have a decrease in your venous return, and then suddenly your left ventricle will take over again the normal shape or how it should look like. So you'll have like a essentially D-shaped septum caused by inspiration. And this is your pulsus, this is equivalent to your pulsus paradoxus. So you'll see this change, this behavior change in your what we call ventricular interdependence based on inspiration expiration in the context of tamponade. So one of the things the first thing you do when you suspect tamponade is confirm that there's tamponade physiology or you want to, there's a few findings on echo that you want to look at. And then the first one is really make sure there's a pericardial effusion. You want to look at it and see if it's fully circumferential. Is it loculated? Is it localized? Because that will also change your approach to pericardiocentesis. An effusion can also look complex with fibrinous components, maybe clots inside, especially, let's say your patient had recent cardiac surgery or intervention. Clots tend to go more posterior, so you'll see more in the posterior aspect, not the interior. And you want to look to see if the fluid looks kind of nice and black, so that there's no cells or fibrinous component to it. It might tell you that it's going to be easier to aspirate. It can also be a clue of what's happening. So if you suspect essentially that this is a massive clot, or you suspect that this is a rapid accumulation, for example, the patient suddenly change and you see this echogenic material, for example, from a free wall rupture or aortic dissection, technically ultrasound guided pericardiocentesis is not your best approach. If you can get a surgical pericardiocentesis, this is what you want. Obviously, if you don't have the time to go to surgical, then you'll have to do your ultrasound guided pericardiocentesis with a few caveats that I'll explain a bit later. Things that you'll see with tamponade on POCUS is obviously right-sided chambers collapse. So you're going to look at your RV and your right atrium for collapse, especially during diastole, when the pressure in your pericardium will prevent your ventricles to fully expand. The right atrial collapse, because there's less pressure, because also the walls are thinner, will collapse sooner than your right ventricle. And that might be an indication that it's a bit more sensitive than your RV to detect tamponade physiology. The inspiratory bulge is what I recently just showed you, the interventricular dependence. So you can look for, as the patient goes in and out, if there's a septum deviation or a D-shaped septum in your cardiac views based on the breathing. And that equates a bit to your pulsus paradoxus. And then the Doppler flows and velocity, again, with expiration inspiration, it's not something that we'll do at the bedside. It's something that a formal evaluation by your cardiologist, I mean, you can take the time to do it, but really you don't need to go in that much depth. You can look at the IVC, see if it's dilated hepatic veins. You see that the IVC is plethoric, if you're not sure as well, but usually the clinical signs and symptoms and just looking at the ventricles, just looking at the effusion will help you make that decision clear. This is to show a bit what happens to your right ventricle during tamponade physiology. So usually we can connect our ultrasound machines to the ECG monitoring, so you can have real time. You can see the essentially lead 2 of your patient as your ultrasound in them. And if you put the M mode right in the middle of your right ventricle free wall, you want that ventricle wall, by the way, to be as perpendicular to your ultrasound as possible. You can see that first you have an initial drop. So your ventricle is going inwards during systole as it's contracting. And then at the end of your T wave, diastole starts. Here you have another drop of your ventricle, which is not normal. This is the drop. This is the ventricular, essentially diastolic collapse, if you want, during diastole. And the more this is prominent towards the end of diastole, the more significant this becomes. That's something you can look at, and it's fairly quick and easy to look at. This is, again, a bit the same thing where we're putting the M mode. This is the right ventricle here. This is the right ventricle here. It's hard to see a bit of T waves, but after the T wave diastole starts, and you still have essentially the RV collapse during diastole. Contraindications to pericardiocentesis, really there's none, because you're doing this in cardiac tamponade. The patient is dying. You're doing this as a last resort. So there's no absolute contraindication to it. Now, the caveat that I want to talk about is aortic dissection and free wall rupture. So the theory is that if you remove that blood, that's essentially tamponading, you might kill the patient. So obviously, if you suspect that etiology, surgical is the best course of action, but there'll be a delay probably before this happens. So what you can do is you take your ultrasound, you do an ultrasound pericardiocentesis, but don't remove a lot of fluid at a time. Go very slow, cc by cc when you get the fluid, just enough to keep the blood pressure elevated above 90 systolic. So you go slow and obviously try to give some more blood to temporize until the surgical approach can be completed. And then there is relative contraindications like look at the anticoagulation, platelet count, but really I don't think they apply because you're doing this when the patient is dying. So who cares about relative contraindications? The complications of pericardiocentesis, this is like for all approach, essentially, been mentioned between like 0.3 to 4% and minor up to 20%. Really the major are death, obviously, cardiac chamber injury. One thing we have to be careful as well is if you can poke the coronary artery or intercostal vessels. Depending on your approach, there's a high risk of pneumothorax or abdominal viscera injury. If you poke the myocardium, you can also get ventricular arrhythmias. You can inject air in that chamber. There's something called pericardial decompression syndrome. And that is especially important to know about if you're a bit rural and you don't have necessarily, you'll be with the patient for transport, you'll have the patient with you for several hours, is that as you remove fluid from the pericardial chambers, there's a very high preload from the right side, and there's a very high afterload because you were in shock, and there's a very high catecholamine, you're in a very high catecholamine surge. And as you decompress the left ventricle can become overloaded from a sudden rush of preload with a very high afterload, and suddenly your ventricle can't cope with that, and essentially you go into shock. There's not much you can do to prevent that as far as we know right now. But it's something to know if your patient crashes a few hours after you successfully done your pericardiocentesis. So what is the best approach for pericardiocentesis? So this has been a bit controversial and debated. You know, Marton actually is the first one who developed the subcostal approach. And then the Mayo Clinic is the first one who essentially introduced ultrasound-guided pericardiocentesis. If you talk to some of the guys who do this often, they'll say, well, you know, there's not just one good approach. You go with where's the biggest pericardial effusion. So you can have your cardiac views, your parasternal long axis, your parasternal short axis, your apical views, your subxiphoid approach. You look, where's the biggest pocket of fluid? And then that should guide where you go. I want to challenge that a bit to say that if we're going to do this in the emergency room, or if you don't have a lot of experience with it, there's probably one approach. It would be the first one I would try to see if I could do that approach. I think it's probably safer and easier to do with less chance of complications. And it will just bring down the level of anxiety of doing the procedure quite a bit if you use that approach. So just to go quickly through the different approach, my probably favorite is the parasternal long axis approach, which would be an in-plane technique. A lot of the different approach will use a cardiac phaser probe. So low frequency probe, because of where you are, you won't have necessarily have good visualization with a linear probe. So you'll be stuck and you'll have to use a low frequency probe, which means that you'll compromise your needle visualization a bit from that. So the good thing about the parasternal long approach is that oftentimes with the linear probe, you'll be able to see your quite well your pericardial cavity, and you just need to see enough that to see the effusion essentially, and see a tiny bit the myocardium as well. The parasternal short approach essentially is just looking at if there's a big effusion. If you have a parasternal short good view, I would say go parasternal long, go in plane technique to do your procedure. You don't need to stay in that view to do your procedure. It's a good view to look at that ventricular interdependence I spoke a bit earlier about. The apical is the more classically described technique where you're going to use the cardiac probe, generate a apical 4-chamber view, and essentially you're going to hopefully find the biggest pocket of fluid and go a bit lateral to your probe, use an in-plane technique, and try to to insert your needle exactly in the pericardial cavity. Now, because of your location, the chance of creating a pneumothorax is quite high. The subxiphoid approach essentially was the first one described by Marton blindly, but that is essentially going, it's a subcostal approach. The risk of abdominal viscera injury or puncture is quite high. Essentially, if you see in this view, you can actually see that there's a liver that acts as a window. To try to avoid hitting the liver as you're doing this procedure is quite difficult. So different people, depending on who you speak with, they'll say use the approach that you have the biggest pericardial effusion. But I want to challenge them on is really, I will go over a technique with the pastoral lung approach where it should be much safer, and you only need essentially an effusion that is at least 1 centimeter in thickness in your pastoral lung approach. Also, whenever you look at an effusion like this, it's important to understand how the patient is positioned. So if you're going to do a apical 4-chamber approach, you might want to have the patient slightly reclined, slightly on the lateral decubitus, maybe 30 degrees, to kind of try to pool that fluid all in one location to make it safer. So don't be afraid to mobilize a bit your patient to help yourself doing that procedure. This is one of the standard kits we have at the Jewish. Essentially, it's a pigtail. Usually there's 2 kits. It comes in a 6 French and 8.3 French size. I would say always do the bigger size pigtail. The reason being that the 6 French after can sometimes kink, and then you won't get as much fluid that you want, and it will cause a lot of anxiety if you don't get any return. So use the bigger size catheter if you're going to do it to prevent that. It also comes with a small bag here to connect to your pigtail. After that, to accumulate, I would say you can throw that in the garbage. Just connect it to a pleurovac. Use an adapter, connect your tubing to the pleurovac system, and that's essentially bigger and better, especially if you're going to transport this patient afterwards. So this is the technique that I want to cover a bit. Essentially, it's a parasternal in-plane and real-time technique, which essentially makes you use a linear probe with an in-plane technique to do a procedure essentially properly live guided. You have a better needle visualization at all time, and you only need an effusion anteriorly of 1 centimeter to say that you can do this safely. Okay, so first you have the patient supine. Machine should be opposite to you, so you only have to look up. So on the left of the patient, it'll be on the right. I'll show you a quick video clip afterwards detailing this technique. Obviously, you prep with your stellar technique. First, identify sternum, and then identify essentially your the pericardial space. And what's important is you'll need to probe. You'll need initially a probe to make sure your landmarks is proper with the cardiac phase array, because oftentimes you might not even see, it might be hard to identify the heart within your probe if there's a large effusion. So use the cardiac phase array to make sure your landmarking is proper. Once you identify the cardiac notch, this is essentially where there's no pleura in front of your heart, switch to the linear probe. Find the internal mammary artery. That's usually a bit more lateral to it's going to be more lateral to your sternum. This is a structure you want to avoid. It doesn't take much time to identify. You can use your color Doppler to identify the nice big pulse of the artery, and then you just avoid that structure. Identify as well, go a bit more lateral, identify where there's lung sliding. Okay, so you know where you don't want to put the needle. Okay, so you know how big is your cardiac notch from sternum to lung sliding laterally. And then identify where there's the biggest effusion in that view. Then you just optimize your image. So you don't need to see the whole heart. Just see the pericardial effusion. You need to see just the anterior wall of your ventricle. And then that is the image you want to trigger. Turn it on your screen. Then you use an in-plane technique. The in-plane technique is really from medial to lateral. So you can see your needle at all time until you enter your needle into the pericardial effusion. As a standard procedure, everybody confirms needle placement essentially with agitated saline. So you can quickly do it, make sure you're perfect, my needle is in the right position. And then you can insert your sheath, your guide wire, you dilate, the same thing as a central line, and you insert your pigtail. When they looked at doing this procedure, the rate of complications was 0, and the success was 100%. It was a small quantity of patients though. They only did it over 3 years. They had maybe like 15 patients that they did it in the emergency room. And the average time to needle, so needle to go and enter the pericardial cavity was 1 minute and 50 seconds, so quite fast. And to insert the catheter was 3 minutes and a half to almost complete everything. So we'll just go and quickly see the video of how this is performed. So first is landmarking. The machine is opposite to the operator, and he identifies the internal mammary artery. Then you can see that there's a bigger pocket of fluid a bit more laterally here, so that's where it's going to go. In-plane technique with the needle. And here in the image, you'll see the pericardial effusion. You see the free wall, and you can see a needle penetrating the pericardial effusion. You see your bevel of the needle right here. And then at that point, he's going to aspirate some fluid. What's nice about this is, you're still far away from the free wall. And then the next thing when you're there is usually on your needle, most needles will have a sheath. You can push the sheath a bit further, so that just over your bevel. So it prevents, as you would draw fluid, or if the heart is moving quite a bit, to puncture the wall. Here they're just going to create a bit of agitated saline. They confirm the needle placement. They're going to insert the J wire, and there you go. So they're going to inject the J. They're going to insert the J wire, and it's a normal cylinder technique for the rest. You can actually confirm that the J wire is in the proper position before you dilate, a bit like you would do with a central line. The main limitation of this technique is you need at least 1 centimeter of a pericardial effusion interiorly. And some pericardial effusion that can cause tamponade are not always interior. They can be loculated, they can be only posterior, like I said. So that is the limitation of this. If you practice your lumbar puncture, if you practice your needle, your IV access with ultrasound, if you practice your arthrocentesis, this procedure is very simple. Because it's the same in-plane technique. Removing the dilator, then they're going to insert the pigtail afterwards. And the video is almost finished. Now, usually when you enter your needle, okay, before you insert the pigtail, you want to remove a few cc's, ideally until the blood pressure comes back to what you want. So the patient is in shock, dying. So before you insert your pigtail, remove a few cc's, and you won't need to remove much to have a good, to have an improvement in the patient's blood pressure. So once you've stabilized the patient, then finish your procedure with the pigtail. And this is essentially the parasternal in-plane technique. The same technique applies if you have a loculated effusion at the apex, but you might need to use the cardiac probe, which will make needle visualization much more difficult. But essentially, it's the same technique. Any questions?
I have a question. For the Puncture syndrome, do we need to have a central line and vasopressor just bedside, like in case we want to transfer the patient just to avoid the shock?
So you should resuscitate your patient essentially. So that's a very good point. So ideally, if you do this and you have the time, you should have actually blood nearby. You should have the butamine that can help, and fluid as well to try to increase your preload. Now, the fluid that you want to give to increase the preload, go with small increments at a time, because you could overload the heart if you give too much. So go by like little boluses of 250, 500 at a time to kind of improve the cardiac function. But try to resuscitate medically, and it will be a bridge to your procedure as well. And as you are going to transport the patient, you leave the pigtail in place, you have your pleurovac. So if there's any issue, you can actually withdraw a bit more fluid in that case. Usually, when we have a pigtail in place, we'll remove a bit of fluid every 4 to 6 hours. And most of the times after 24 hours, there's enough fluid out that you will not have tamponade again, even if you remove your catheter. To remove the catheter, usually you want over 24 hours, I think less than 20 cc's of exudate. But it's a very good question. Yes, stabilize your patient. So that means still the same resuscitation, pressors, fluid, blood.
Great. Any other questions for Paul?
I guess I just like the tip of asking cardiologists to practice. And like the Jewish Mardigan does it, and most of them are super nice at the CCU. If you ask them, they'll let you come in and tell you.
Yeah, this is a halo event. You know, like I've never had to do this in my career. I would say most people won't have to do it in their career probably, depending on also where you work, rural versus like a tertiary care center. So it's something that you have to know how to do it, visualize it mentally, and if you can, practice with stable patients. And for us, it would be with the cardiology department, sometimes assisting to some of those procedures.
Awesome. All right. Well, we're at that point in the morning where, in essence, thank you so much, Paul. Like, it's a great presentation, and all the presentations this morning were fabulous. We're at a point now where we thought that we'd have just a panel discussion or panel question period, if for basically just everything you wanted to know, but were afraid to ask about POCUS. So this is a free-for-all session now for, let's say, the next 10 minutes. We'll limit it at that. If there are more questions, and yeah.
I know a lot of the questions were asked during the presentation. Is possible there's none, but you have a panel of superstar experts, so go for it if you have one.
And if you don't, that's okay, but you will have at one point, and don't hesitate if ever one of us is in the emerge and you want to try to do one, just go for it. I think it's important that you practice. And if you have any questions at another time, feel free to send us an email. It's going to be a pleasure to answer.
I also think that for those who are hesitant, I think once you get the first one under your belt, you recognize that it's not as complicated as that. So again, start with the simple ones, start with the ones that don't have any complications. If you're going to come to me and you've never done one before and you say, can I do an interscalene block? I'll say, well, let's do something a little bit less complicated first. But once you get it done, and once you understand, the hand-eye coordination and the injection, whatever, all the other procedures are more or less the same, and you'll have a much more easy time to start doing the procedure.
Yeah, for sure. I found even just with lumbar punctures, doing it on that easy patient really boosted my confidence using the POCUS for that. So. If there are no other questions, I think Anso and I both just want to say a huge thank you again to all of the presenters. this was a great morning. And I think, silver lining to the fact that we weren't able to do this in person is that a lot of people were able to participate. We had quite a good audience today. And a huge thank you as well to Laurie. I think she deserves to be singled out because she emergently reorganized this day. From being in person to getting these presentations sort of somewhat coordinated and organized. So thank you again, Laurie, and everyone who presented. That was awesome.